right. Welcome back, everyone. Thank you all for joining us for another wonderful week. This is an exciting week because we finally start oncology. The past few weeks, you were learning about immunology. So very excited for these next few weeks. So you made it through immunology. This is, it's a nice segue. So the material that we're going to be discussing today is a segue and a combination of really about using the power of the immune system to fight malignancies. So that's going to be really the focus of the lectures today. So did anyone have a fun weekend? Anyone do anything fun? Study oncology. Okay. I know, you guys, no, come on. Someone did something fun. No one? Anyone read new books? Watch a new movie? You did? What was the movie you watched?
On Netflix, they have this show called Mindhunters.
Uh-huh.
All criminal, like FBI interviewing all criminals.
Oh, Mindhunters.
Binge watched it over 2 weeks.
Okay. Well, that's fun. So what is everyone's thoughts about the Oscar nominations, how Margot Robbie got snubbed out of an Oscar nomination? You don't think she deserves Best Actress? All right. So I heard, actually a couple announcements before we dive in. So one thing is just announcements on the quizzes. So I know our TAs have been receiving a lot of emails. So, just be cautious before you submit your quizzes. If you submit them without completing all the answers, we're not able to reopen the quiz. So just be cautious when you open the quiz. Make sure everything is selected, the right answers are selected, or whatever answers you select, and then go ahead and submit them. So we can't reopen them if you submit them early, just out of fairness for everyone else. A lot of you, so last week I asked, if any of you are interested in doing an article with Pharmacy Times with me. So I received about 40 different emails from you all. So, of course, for this first article, I was only able to select the first few that emailed me. But certainly there'll be more opportunities in the future. So, I'll certainly keep all your emails. I know I didn't respond to all of you, but I have all of your emails. And if anything opens up in the future, which I'm sure there will in the next few months, I'll certainly loop you in. So don't worry, you still have time to be involved in different things. I heard API rotations came out. So some people are happy, or are most people happy about it? Yes? You're never going to have a perfect schedule, right? So how many of you got an oncology rotation? Yeah? Who got a Norris rotation? Oh, wow. That's like more than I thought. You're great. All right. Well, that's exciting. Who got City of Hope? All right. Well, you're probably going to be meeting a few of your preceptors. Starting today, we'll have a preceptor be joining us, and I'll introduce him shortly. So, did anyone want an oncology rotation but not get one? Okay, so it's a decent amount. So I'll just share with you this. I did not have an oncology rotation as a student. So as I mentioned on the first week of the course, I did not enjoy oncology when I had it. And it wasn't until my residency where I started falling in love with the material and the subject. So don't be alarmed, don't be worried. Certainly everything can still work out if you don't have an oncology API rotation. If you ever want to shadow or stop by and understand what it is, if you didn't receive a rotation, feel free to reach out and we can connect you with some of our preceptors as well. I think they'll be happy to kind of show you what oncology pharmacy is like. All right. What else we got? So, make sure I covered everything. I know there's elephant in the room, there's a midterm next week. So in the second half of the course, once we sit down and figure out some of the more final details, I'll give you some updates about the midterm next week. So any questions before we dive into the material this week? I'll give you more information in the second half. Okay. Any questions before we get started? All right. So again, this is going to be your first oncology type lecture that you'll be receiving. So today, exciting topics that we'll be covering. Again, using the power of your immune system to fight malignancy, starting off with the subjects of bone marrow transplantation and then moving into CAR T cellular therapies. So I like to start off by actually giving you a brief history of bone marrow transplantation. So you can kind of see on this slide, this started back in 1949. 1949, the question was asked, could mice survive a lethal dose of radiation and be rescued by using bone marrow cells? And the answer was yes. So they actually wiped out the entire mouse's bone marrow reserve, gave stem cells, and the mouse survived. But unfortunately, the mouse died about 30 days later from something now known as acute graft versus host disease that we'll be discussing and that you learned about in the asynchronous material. This was the first case. So you can see in 1974. So this was a publication, New England Journal of Medicine, that showed the first case of a bone marrow transplant between identical twins. And actually, one of the authors here, so Donald Thomas, won a Nobel Peace Prize, for actually his work on this bone marrow transplant. In fact, one of these identical twins is still alive today after receiving this bone marrow transplant. So certainly rich history. So it started in 1974 with patients, and really the field has exploded ever since then. So before I jump to the next slide, can someone answer the question, why do we do bone marrow transplants? Why do we do them? What's the purpose? So to replenish the cells that you lost from chemoradiation. Anything else? To what the immune system? Regulate the immune system. Okay. A new cellular lineage from a donor. Yeah. So you can see there's a lot of different reasons, and we really separate it between, there's two types, as you learned. There's an autologous bone marrow transplant and an allogeneic bone marrow transplant, and you can see kind of the purposes of these transplants may differ. So we know that first off, the chemotherapy that we give, the conditioning regimen that we give, kills the cancer cells, right? So that's one of the reasons. So higher doses of chemotherapy kill those cancer cells that are resistant to conventional doses of chemotherapy. And if we want to use an autologous bone marrow transplant, one of the purposes there is one of the dose-limiting toxicities of some of these chemotherapies is bone marrow suppression. So you're giving very high doses of chemotherapy that wipe out your stem cells, so you need rescue cells to replete your stem cells. So those are autologous bone marrow transplants. And when we talk about allogeneic bone marrow transplant, we have this concept of graft versus tumor, graft versus leukemic effect, where essentially you're using the healthy donor's immune system, right, to fight any residual cancer cells. So that's really the purpose over there. You can see on this slide, so this is data that we have from the Centers of International Blood and Marrow Transplant. So it's a very reputable organization that often regulates us and provides research for bone marrow transplantation. You can see the rates of BMT over the years. So starting off from the 80s until now. So in green is the auto transplants, and in blue the allogeneic transplants. So you can see them steadily increasing. You can see now in the past few years there's been a bit of a plateau. These are U.S. numbers, by the way. I'll just share with you the figures that we do at Norris. So at Norris, each year we do about 60 allogeneic bone marrow transplants and around 100 autologous bone marrow transplants. Yes? Is that a lot? How much does City of Hope do, Brian? A lot? I think their numbers are around double ours, at least. Yeah, around double ours. I think we're about average, the numbers we do at USC. Of course, City of Hope now is a national organization, so they have a lot of referrals. So they're a little bit larger than USC, but certainly, we do a lot of transplants for these patients. Here's a breakdown about, in terms of the malignancies that we're treating with these bone marrow transplants. So you can see, in terms of allo, acute myeloid leukemia is probably one of the biggest allo transplants we do, followed by MDS patients. And for autologous transplants, multiple myeloma kind of leads the way there. I'm one of the minority. I think we should be doing less auto transplants for myeloma, but certainly you can see a lot of cases there. Okay. All right. We're going to transition and do a little bit review for the next 15 minutes or so from some of the material and kind of dive in a little bit more into donor selection for these patients. So you learned there's different donor sources for allogeneic bone marrow transplants. So you have an individual with a malignancy and you want to find a healthy donor. So what's the first step? What do you guys think? What was that? Look at the family, right? So you can see one of the gold standards we have is finding a matched sibling or related donor. So a perfect matched sibling or related donor, that's the gold standard. That's what we like to see for patients. If we can't find that, we try to look for a matched unrelated donor. And we look at the donor registry for that. So we'll talk about Be the Match shortly. And then it kind of just goes from there. So then you're looking for mismatched patients or haplos. So haplos, who remembers what a haplo is? Haplo? So we'll talk about HLA on the next slide. So a haplo is usually like a sibling or a parent. So you receive half of your HLA from your dad and half from your mom, right? So haplo is a 50% match with the other person. So, my sister, for example, would be haplo with me. So that's, haplo transplants, a 50% match used to be considered very high risk of graft versus host disease because of that mismatch. But we've certainly come a long way in our treatments of bone marrow transplants. Now, a lot of our patients are getting haplo transplants because we've really strengthened some of our regimens to prevent graft versus host disease. So looking at HLA here. So HLA is essentially these surface proteins that differentiate one person from another, right? And these are surface proteins on white blood cells and other tissues. And the most important HLAs that we use for matching patients for bone marrow transplants are these first four, right? HLA-A, B, C, and DRB1. So if you look at two people and these match 100%, then you're considered actually a perfect match. Now, there are there's other factors now we're understanding. So DQ and DP not listed here, where if DP and DQ also match, you're considered to be 12 out of 12. So it's an additional match for these patients. So 8 out of 8 still considered a perfect match, but if you have DQ and DP, those are slightly better matches for those patients. So these are some of the things we look at when we're trying to decide on which donor to select. And you can see besides HLA, there's other factors as well when we're trying to find a donor. So we have two people, we have maybe multiple donor options, and we're trying to decide who would be the best possible donor for this patient. So age is another factor. Younger patients are preferred. Male donors are preferred simply because of that immunological problem. Same thing with female donors that have more children. Blood type, so certainly, blood type can be a factor as well, but that's not a sole determinant for patients. We can, if a patient's not compatible in terms of their red blood cells, we often have methods to either, wash out those red blood cells or desensitize the patients. And if they have CMV, does anyone know what CMV is? You learned it from the lecture. Cytomegalovirus. So how many of you here think you have CMV? So most people have it. That's right. So it's an opportunistic infection, and it's really a concern when you become immunosuppressed. Or so after transplantation, when patients are on immunosuppression, the CMV can start flaring up for these patients. So now we're going to dive in for the next 5-10 minutes about Be the Match. So I think Dr. Lee did a wonderful job of introducing you to Be the Match, but I'm going to show you this quick video about some of the power that Be the Match has.
You're going to meet this wonderful woman right here because we have a lot in common. Many of you know that I have a rare blood disease. It's got a big old long name to it. Its nickname is MDS, pre-leukemia. And I'm going to undergo a bone marrow transplant in just a couple of weeks now. I'm just one of thousands of patients who need this kind of transplant. And in a perfect world, we would all be matched up with donors. I'm blessed that my sister is one. The happy ending to the story of the woman that's sitting to me right next to me right now, I can't wait. And you're going to meet the man, the young man who gave you the gift of life. But before we have that reunion, Erica, we want to show people your story.
Thank you.
Okay. For Erica Turner, life as a happily married mother of two came to a screeching halt. Her world stopped with a simple statement from her doctor.
He said, Mrs. Turner, we believe that you have leukemia. And I looked at him and I said, cancer of the blood? It felt like somebody just hit me with a low blow.
And her condition was spiraling. She was getting sicker.
It's a very aggressive leukemia.
Even with chemo and radiation, there was only one life-saving solution.
I had to have a bone marrow transplant. That was my only option to survive.
Erica was an inspiration to her medical team.
She was filled with hope. She was filled with joy. She's filled with love. And I helped carry everybody who was taking care of her through.
A very tough battle. For African Americans and other minorities, it is harder to find a bone marrow match.
The likelihood of finding an African American donor is about 60%. A little bit higher for Hispanics, it's about 70%. And for Caucasians, it's in the realm of 90%.
But after weeks of waiting, and as Erica's condition worsened, a bright light arrived in a fax. A match for Erica, and even better news.
They were a perfect match, yes.
The zeros on the bottom say their blood proteins are no different, that they are an absolutely perfect match, a 10 for 10 they call it.
It was a male, and that he was a senior in college. That's all I knew.
But when final preparations came for her transplant, Erica was about to give up.
I was burnt out. I was tired. I didn't want to go. I fussed, I fought, I cried, and my husband said, fine, get back in bed and we'll watch you die. I jumped up, I said, I'm gonna die? I'm gonna show you.
The transplant worked, and soon Erica was in remission. But there is one more stop on Erica's journey.
I've never met him, I've never seen him, but I'm just so excited to look into his eyes, to look into his soul and tell him thank you. I just want him to know that he is my hero.
When people are faced with the potential that they might die, and they have to rely on the kindness of a total stranger, and they say yes, and everything comes together, it's a pretty miraculous story, and it's a journey.
And this doesn't give you goosebumps. I don't know what will.
Fighting back tears.
I know that you are. You ready to meet him? You ready to meet this young man?
I'm ready to meet the man who saved my life.
It gives us such great pleasure to bring out Christopher Magoon, the young man who saved Erica's life. There he is!
Thank you. Thank you. It's good to meet you. Finally. You look great. Bless you.
So certainly you can see the power of a bone marrow transplant. So, these patients, this patient over here diagnosed with either MDS or AML, you get them in remission with chemotherapy, but in order to provide them with long-lasting remission and cure, you need to perform a bone marrow transplant for these patients. And so, you heard from the video, and we talked about how challenging it is for these patients. Oftentimes, if this patient didn't have a sibling, there's no haplo option for them. They rely on the kindness of others to have a bone marrow transplant and have a match with someone. Certainly, we've had some amazing cases. So this patient on this slide over here, this is on the USC website. So this is a patient that Lakshmi treated, your next lecturer, Michael Snow, who's a prominent LA musician, who was treated, received a bone marrow transplant, is doing fine now. In fact, so he invited Lakshmi to go to his concert. I think you attended, right, Lakshmi? So it was a fantastic kind of story for these patients. We had another patient too, who his daughter was getting married soon, and his hope was to live long enough to be at his daughter's wedding, to dance at his daughter's wedding. And he wasn't sure if he would make it. And guess who his BMT donor was? His daughter. So his daughter provided him with the bone marrow transplant. He was in remission and was at the wedding, and I think a couple of the BMT folks were invited to that wedding as well, and saw that. So it's certainly very, very amazing stories, and the impacts that these patients can make is tremendous. So, now we're in these last few slides talking about what Be the Match is. So you can see their mission statement here to really find these volunteer donors and match them up with these patients. So finding a suitable donor is not an easy task for these patients. So you see 60% of these patients do not have a match in their family. Match rates are higher for Caucasian patients, but lower for other patients. So that's mostly because the donor registry is lacking in diversity. Less African American patients, less Asian patients in the registry. So diversity certainly crucial for these patients. So we talked about, so you saw this patient in the video, when can you meet your donor? So it's about a year in, and both parties have to consent, but I think most typically do. And so it's certainly an amazing journey for these patients to meet each other. So I have different members of my family that are on the registry. And so this is a patient, we got permission to share her information, that my younger cousin registered on Be the Match, and she ended up actually being a match for this patient right here. So she got a call. So when she registered, she got a call about 2 years after she registered. And, it turns out that she was a perfect match for this pediatric patient that had ALL. Right, so an ALL is a type of leukemia that hits pediatric patients. And bone marrow transplant's the main way you're able to treat these patients. So my cousin got the call. She said yes. They flew her out to another state. They did the bone marrow apheresis, which essentially you just gave my cousin growth factor to stimulate her bone marrow cells, and it's kind of like almost like a dialysis. So they're not actually going into your bone marrow as much anymore. So now it's just kind of like an apheresis, which is kind of like a dialysis. And they gathered the stem cells, and they gave it to the patient a few days later. And actually, they still keep in touch. So I went with my cousin to this appointment. And actually, so this was about 2 years ago, and they talk on the phone almost monthly. So certainly, amazing connection that you can make for these patients. So if you haven't considered it, I urge you to kind of think about it, have a conversation with your family members, think about it, think about the possibility of joining the registry. So you can see the website on the slide, so marrow.org. It's very easy. So essentially, you go on the website, you fill out a form. It kind of lets you know if you meet the criteria to become a donor. Once you meet the criteria, they mail you a couple swabs. So a kit with a couple swabs. You do a cheek swab, you send it back, and then you're on the registry. You may or may not ever receive a phone call. So there's certainly some that are on the registry for their whole life and never receive a call, and some do receive a call. So it depends if you're a match with the patient. So it's certainly the whole process is free, even if you have to donate. And you can see from the stories that we're sharing, the video that you saw, you do save lives by doing this very non-invasive donation for patients. That's me doing it about 2 years ago. So certainly an amazing thing to do. And so I know. So I encourage you to all think about it, and you could be the cure. Okay? Any questions before we transition to the next portion of the lecture? Yes. The whole process, so it's not that long. So if you get the call, you'll start off with something called mobilization, which they give you Neupogen, which is GCSF, to stimulate your bone marrow cells about 5 days or so. Then you go do apheresis, which is kind of like a dialysis, but it's filtering out your CD34, which is your stem cells. That takes about a day or two. And then that's the whole process. So there is some screening before that to make sure you're a good match, though, right? So, infectious workup, x-rays, and things like that, making sure that you're a healthy donor yourself. So there's a couple portions in there, but certainly not too lengthy of a process. They fund the whole thing, cover everything from A to Z, your airfare, your housing, and everything. And most employers will give you time off for that, right, by law. No, I mean, there've been a lot of studies on this. So for the most part, nothing has been proven to have any side effects for these patients. So, they're just giving you some Neupogen, and so patients are fine after that. Main side effect of Neupogen is bone pain. So that's kind of something that patients experience, but other than that, pretty low risk. Okay? So I'm excited to now welcome 2 lecturers today. So you have actually a total of 3, but for the first portion of the presentation today, we're going to be focusing on a little bit more details on bone marrow transplantation. We have 2 wonderful lecturers for you today. First lecturer, Lakshmi, she's our fabulous PA. I thought it would be helpful to have some PA insight because the rest of your lecturers are all PharmDs. So Lakshmi is one of our fabulous APPs at Norris. So I work very closely with her in the bone marrow transplant clinic. She sees essentially all of our bone marrow transplant patients and takes care of them from A to Z. Fabulous wealth of experience. So she's going to be starting off your lecture. And we also have Dr. Brian Lee, who recorded the asynchronous material. He's from City of Hope, so definitely one of my close colleagues. We always talk to each other whenever we have a complex patient, try to decide on how to treat the patient. So he's essentially my counterpart at City of Hope. So very thankful for Brian, Dr. Lee, for joining us today. So Lakshmi, if you want to join me, we'll go ahead and get started.
Hi everyone, my name is Brian. I couldn't agree more with Amir or Dr. Ali. I don't know if you guys already watched the asynchronous part. It's okay if you haven't. I'm going to try to do some very brief re-review, but try not to reiterate so much of what I said already in the asynchronous. But of course, Be the Match is so important. Being a part of the bone marrow donor registry is so important. And unfortunately, people only find out about Be the Match when it's a friend or family member that needs a donor. That's why we try to bring awareness to it. It's something that a lot of like just regular people like us don't know about. But once it really matters, it does really matter. So it's just kind of better just to, you know, proactively be part of the registry. So like I said, I'm going to try to not reiterate too much of what I said in the asynchronous, but just try to focus on some of the key points. And so I'll do the first third to half of the lecture, and then I'll be passing it on to Lakshmi, who will provide a lot of patient-facing experience and a lot of her own personal experience as well. So going into the science of transplant and some of the more granular and fine details. So I already talked about this slide a lot in the asynchronous lecture, but basically to understand bone marrow transplant, it's really important to know the origin story of your blood cells, how you get red blood cells, white blood cells, and platelets from your stem cells. And the way these stem cells mature and grow is key to understanding how blood cancers occur, as well as how we need to recreate the immune system for these patients. So the key point in this lecture will be reiterated a lot, but autologous transplant is a completely different entity than allogeneic transplant. So autologous transplant, as the name implies, auto or self. Autologous transplant is more of a stem cell rescue, and kind of reiterating what Dr. Ali said and going into the science of it, there are some cancers whose curative potential or treatment is dependent on the intensity of the treatment. So, and this is not true for all cancers, but basically some cancers respond to extremely high doses of chemotherapy. These doses of chemotherapy are not things that we can survive, and however, they do work for treating the cancer. We'll discuss a lot in the oncology lectures moving forwards on how traditional chemotherapy, as opposed to some of the newer technologies, it works, but it's very abrasive. As you imagine, you're injecting, you know, poisons, toxins into your body. They kill the cancer cells very well. They also kill your cells very well too. And there's still a place for them because they have been effective. They have a lot of history, even though we have so many new therapies as well. So to treat these cancers that do respond to intensive chemo, you want to give as much chemotherapy as someone can survive. So you harvest their stem cells first. You push out the stem cells into the peripheral blood using GCSF growth factors. As Dr. Ali mentioned, very harmless. People get growth factors for other conditions as well. Collect the the stem cells, similar to donating blood. That's how stem cells are collected usually. And then the patient is given their chemotherapy, radiation, whatever it is. Very intense, very toxic, hoping to cure the patient. And then the patient is in a very difficult state. You've just blasted them with everything you have. And then you return the stem cells back to them because they are not going to be able to recreate their cells at that point. Give them the stem cells back. The stem cells find their way back into the bone marrow, and then they recreate the blood cells. And then hopefully the patient survives, and they survive cancer-free because you just destroyed all the cancer in their body. This is primarily used for blood cancers, by the way. And then there's allogeneic transplant. Completely different entity, allogeneic transplant. So allo means from someone else. This is what we more traditionally think of conceptually as a transplant because you're taking something from someone else and then putting it into someone. So this is stem cells received from a donor, not yourself. And it's going to completely replace your own stem cells, which have been destroyed by treatment as well. But here, to achieve some kind of cure or remission in a patient, you're not depending on the intensity of chemotherapy that was given beforehand or radiation. That chemotherapy or radiation sometimes isn't as intense and is more of a primer to prepare the immune system to accept the donor. What you're really trying to do here is reintroduce a new immune system, and I talk about this in the asynchronous lecture about how cancer occurs and why cancer continues to grow in your body, but I'm just gonna very quickly reiterate it here. Every day you have messed up cells that develop, mutations occur naturally, and your body is very good at getting rid of these messed up cells that develop unwanted mutations. Unfortunately, sometimes in our lives, some of these cells develop ways to escape your immune system. They divide rapidly and they become cancers. And then you need treatment because your immune system is no longer keeping these cells in check. And in certain blood cancers, like Dr. Ali mentioned, like some of the aggressive leukemias and lymphomas, which are blood cancers, even if you just have even one cell surviving in your body, which could hide anywhere because blood goes everywhere, right? That one cell is enough to redivide and just continue the cancer. For these aggressive leukemias, very difficult to treat, and you can't depend on these simplistic drugs or therapies that you have to chase down the very last cell that exists, cancer cell that exists in your body. So you need to depend on immune therapies, and allogeneic transplant is an immune therapy. You're going to replace your entire blood system and immune cells with someone else's stem cells, the stem cells will divide and regrow into a new immune system. And hopefully the donor's immune system is going to see these cancer cells and recognize that, they're cancer cells, they're not right, and they're going to chase every single last one of the blood cancer cells and then remove them and then put you in remission. And that is why it is an immune therapy and much more complex than giving drugs and et cetera, but also in a way much better at navigating your body and deleting these cancer cells that, very simplistic therapies aren't able to get rid of. And so the goal is, of course, it's a treatment modality for blood cancers, but not just blood cancers, also a lot of different other blood and immune disorders. Because when we talk about immune problems and immune dysregulation, I think you guys already had immunology lectures and such, but as you can tell, the immune system is extremely complex, very multimodal. Every single cytokine affects another cytokine, every pathway affects another pathway. And when it comes to a certain point in these immune disorders where drugs and therapies don't work anymore, sometimes you just have to replace the entire immune system. And that's another way of, and doing a blood and marrow transplant is another way of replacing the immune system. Don't want to go too much into this slide. I talked a lot about it in the asynchronous section, but just reiterating the differences between autologous transplant and allogeneic transplant. Autologous transplant is a stem cell rescue. Curative potential depends on high-dose chemotherapy. Allogeneic transplant is an multi-step immune cellular therapy. It depends on something which I was describing earlier, graft versus leukemia or graft versus tumor effect. The donor's graft in your body is going to identify these cancer cells and destroy them. And that is part of the curative potential of these bone marrow transplants. But one thing you have to keep in mind is not only does the graft or the donor cells in your body attack the cancer cells, they also attack you. Depending on the degree of mismatch of the donor, it can be really bad or it can be moderate. There are ways to manage this, but this is called graft versus host disease, which occurs anytime you have an allogeneic transplant. And this is something that also needs to be carefully balanced because graft versus host disease is when the donor's immune cells attack your organs, and this can be devastating, especially as it attacks your major organs, and is one of the main causes of mortality post-transplant. So how is a stem cell transplant performed? Just brief overview. So the timelines look similar, but again, reiterating the differences between autologous and allogeneic transplants. A lot of what happens before the transplant looks similar, but after the transplant, the course is significantly different. In both transplants, after the transplant, we're very concerned about infection, but after the allogeneic transplant, we're also concerned about graft versus host disease, or GVHD, and we also benefit from the graft versus leukemia. And the time to cell line recovery is significantly different between the two transplants. As you might imagine, in an autologous transplant, when you transplant your own stem cells to your body, they need to find their way into your bone and into your bone marrow. When you transplant your own stem cells, they get back into your bone marrow very fast. It's like trying to re-find your new home. This could happen on the order of 1 to 2 weeks or maybe a little longer. Because they're familiar with your body, they are your own stem cells. When you take someone else's stem cells, transfuse them into you, they're in a foreign place, they're trying to find a new home. It takes a long time for them to find their way into their bone marrow and then make a home in your bone marrow and then start producing your cell lines. And so for that reason, there's a very extended period of complete immunocompromisation in these post-allogeneic transplant patients where the infection risk is so high, and the risk for other things as well. Kind of what Dr. Ali mentioned, when the stem cells are removed from the donor, it's a painless process. There is no direct bone marrow harvesting. Well, there is, but it's not as common these days. It's usually done similar to giving blood. As you can see, there's a machine, it's collecting blood. It's going to pick out them stem cells and return the other things back to the blood. Dr. Ali kind of already talked a lot about donor type and stem cell source. The only thing I want to kind of emphasize is what exactly a haploidentical transplant means. So, you know, the ideal kind of match is a match-related donor, right? We have a perfect match. The patient's also related to you. And having a match-related donor would really decrease the risk of graft versus host disease. What is a haploidentical donor and why is it so significant? So as you know, people are not guaranteed to find a match. And if you cannot find a match, that is pretty much a death sentence. However, our understanding of immunology and new technologies have really allowed us to use haploidentical or half matches. So going into kind of like cell bio, you know, you have like gametes and things like that. There's diploid, which has 2 sets of chromosomes, and then there's haploid only having 1 and basically half. So as you might expect, who might be a haploidentical transplant? So who by default shares a minimum of half your chromosomes with you? Yeah, your siblings, your parents. Your parents each gave you 1 set of chromosomes. Your siblings would be a half match. So when you cannot find a match in the registry, which is an unfortunate thing, you would then maybe potentially turn to a haploidentical transplant, your parents, your siblings, and such. This is not ideal, but it is an option, and you really need a lot of options at this point. And newer technologies allow us to use a half match. I'm not going to go into these technologies, but I'm going to talk about the concepts behind them. So in order to make a half match work, you either need to modify the immune portion of the graft or the donor, or modify your own immune response. Everything comes down to immunology. And you either need to make it so the donor cells do not attack you as much through direct cell modification or therapies or drugs, or you need to modify your own immune system to accept this half match, whether it be other technologies or techniques as well. So Dr. Ali already talked a lot about this. The people that are most affected by this health disparity, as you might expect, are the minorities. There's a lot of socioeconomic reasons as well as geographical reasons as well. The European countries are have systems in place that have make it so there are a lot of people enrolled in the registry, and that is why like whites, Caucasians have a very high chance of finding a donor. It's because they tap into the huge European population as well. But the Asian countries, you know, and other countries don't have these kind of systems in place that allow for and promote this kind of enrollment, which is part of the contributing factors as to why it's so difficult to find a match and a donor for the minorities. But yeah, just reiterating again that it's a very difficult health disparity to overcome because this is life or death for someone. So it really matters a lot once you know someone that does need a match. And then going into your transplant timeline. So again, pre-transplant, you've collected the stem cells from the donor. Then there's something called conditioning. What is conditioning? It's the pre-treatment before the transplant. In autologous transplant, it's the very intense chemotherapy and or radiation. Before an allogeneic transplant, it's also chemotherapy with or without radiation, but it doesn't have to be as intense because, of course, the curative potential here is not the intensity of the chemo in allogeneic transplant, but the immune response that's going to occur after the transplant. Not going to go too much into the types of conditioning regimens and the intensity because this is not necessarily focused on that. But just know that there are different intensities to the regimens. And then again, not going into the chemotherapy because this is not a traditional chemotherapy lecture. Just note that there are toxicities when you give chemotherapy before the transplant, as you might expect: nausea, vomiting, mucositis, hemorrhagic cystitis, opportunistic infections, and such. And then there's day 0. So day 0 is when the stem cells are infused into the patient. This is the transplant day. For autologous transplant, this is simply a stem cell infusion. For allogeneic transplant, this is a patient's new birthday because from this point moving forward, their blood cells genetically and phenotypically are going to be someone else's blood cells. And I just have one more slide here before I pass it on. And this is the takeaway for the more science portion of of bone marrow transplant, is that post-transplant, the donor stem cells, they're going to find their way into the bone marrow, take over the empty bone marrow, and begin trilineage hematopoiesis, which is the reproduction or the maturation of the stem cells into the end product, which is white blood cells, red blood cells, and platelets, which is the trilineage. Of course, there's a lot more cells than that. And then post-allogeneic transplant, there's a fine balance between graft versus host disease and graft versus tumor, or graft versus leukemia. So as I mentioned before, graft versus host disease is a bad thing. The graft or the donor is attacking your organs, your skin, your liver, etc. It can be very devastating and eventually lead to death if unmanaged. And then there's graft versus tumor, which is what we want. The graft is hunting after every last cancer cell in your body, and hopefully providing you a remission from blood cancer, etc. So it's kind of a seesaw. It's a balance versus graft versus host and graft versus leukemia. You can't have one without the other because it's the physiology of having a graft within you. And the fine balance is controlled with various factors such as transplant conditions, prophylaxis strategies, and immunosuppressants. So I'm now going to pass it on to Lakshmi, who will talk about post-transplant care, infection management, and some of her own insights as well. And there's a lot of complexities before a transplant, but there's a significant duration of follow-up post-transplant. So a lot of the magic happens post-transplant because while you let the graft or the donor do its work in your body, you need to keep the patient alive. They're in it for the long haul, so you need to keep them free of infections, uncontrolled graft versus host disease, and hopefully bring them into a long and durable remission. So I'll now pass it on. Thank you.
Yeah. So we'll come back at 10? Okay.
Start it again. So, about your midterm. So your midterm is going to be next Tuesday from 1 to 2:30. So it's an hour and a half. It's going to cover lectures 1 through 3. So this material is going to be on the midterm. There's going to be somewhere between 50 to 55 questions on the midterm. It's going to be a mixture, mostly just multiple choice, and only a couple select all that apply, and then also a few case-based questions as well. Okay? Any questions about it? Should be pretty straightforward. I'll try to upload the exam this weekend, so make sure you download it before Tuesday. And I'll send an email reminder as well. Okay? Any questions about it? Yes. The question is, are they case-based practice questions? Oh, well, I mean, so that's what we're going to be doing in class. So the second portion for this lecture is all going to be case-based practice questions that are very similar to the midterm. So you're going to see that. Okay? Anything else? All right. All right, Lakshmi.
Can you guys hear me okay? All right, perfect. All right, guys. Well, thank you for having me. I'm Lakshmi. I work at Norris in the bone marrow transplant. I've been doing this for just about 4 years now. So prior to that, I was in different fields. I did internal medicine, family practice. I did clinical research for 12 years, and then did urology, and then I got bored, and then finally landed in bone marrow transplant. Probably one of the best things I've done in my life. So, you know, what they say, better late than never. So just want to stress, just 30 seconds, please, if you haven't registered, please, please, please register with the Be the Match. I registered 35 years ago, and my odds of being called are very slim because obviously, as the slide showed, they want young, healthy people. I got the health covered, but I'm not so young. So the odds, you know, as years go by, my odds diminish, but you guys are all healthy. So please encourage your family, yourselves, please register. The look on patients' faces when they know that they have a donor is immense, and you know there's nothing more that you can do than giving a gift of life for somebody else. So having said that, so we talked about, or Brian talked about auto and allo transplant. So with auto, they recover pretty quickly. Their hospital stay, their complications are pretty minimal. And please, by no means am I undermining or downplaying the risks associated with auto, but definitely with allo, the risk is very high. The risk for graft versus host infections is very, very high. So we need to safeguard these patients. So if you kind of think about allotransplant, one of the other analogies that one of our doctors use is kind of like getting ready for gardening, right? Like you have a brand new place, you want to do some gardening, you rake it, you get it all healthy, you know, take out all the weeds, prep it, and then you put the seeds and you water it, you watch it grow. But as the plants are coming in, they're still fragile, right? They're not firmly rooted into the ground. So you need to protect them from weeds and, you know, if you have pets, you know, whatever the case may be. So it's essentially, the immune system is essentially the same. So these are all like babies. They have a new birthday. Their immune system is extremely vulnerable. So you have to safeguard them from getting infections. So what infection medications do we use for these patients? Well, they are at a risk from a bacterial perspective, viral perspective, fungal perspective. So you want to cover them for all of the infections. First, in terms of protecting them as their immune system develops. So if they haven't been engrafted completely, engrafted means that the marrow has found its way, the cells, the donor cells have found their way into the marrow, and they're starting to engraft, right? Like you're seeing the sprouts, the seedlings come through. But so you want to make sure that their white cell counts or their absolute neutrophil counts are all up to par, and you want to protect them. And on top of that, as they're developing, they're also on immune suppressive medications, which we'll kind of get into. So you want to take care of them. So you use antibiotics, antiviral, antifungal medications to keep them going. You want to protect them from mucositis, aspergillus, which is a fungal infection. You want to protect them from herpes virus. You want to protect them from Epstein-Barr virus, cytomegalovirus. All of these viruses, so most of them are opportunistic that can have a havoc on their immune system. And one of the other things, you know, just I'm sure with you guys have done infectious disease already, I assume. So with the HIV patients, you've talked about covering them for the pneumocystic, right? Because their CD4 counts are low. So same concept here, the baby immune system, you want to protect them. So you definitely want to protect them for PJP, PCP, which is Bactrim, in addition to other bacterial coverage that we have for these patients. Kind of covered this a little bit. For these patients, another thing to keep in mind is as you prepare them for the transplant allogeneic, you know, you're wiping up their immune system, right? So all of the vaccines that they've gotten as a childhood vaccines are all wiped out. except for one, which I'm not going to really go deep into. So they have no protection for all of these infections. So you really, really want to cover them and be aware. So when you have an allotransplant patient that comes in saying, hey, I have fever, you don't take that lightly when somebody else that walks into your clinic with some fever. So you want to make sure that you're covering all of the bases for their protection. And so there's some guidelines, and there's certain antibiotics that work for certain things and that don't work for something else. So you kind of want to be aware of what is their risk, how do you stratify the risk, and what coverage you want for these patients. So in terms of the antibiotics, levofloxacin, we do that generically for all of our patients that are neutropenic. So neutropenia, if their ANC is less than 500, we automatically put them on levofloxacin. Why do you think we do levofloxacin? What's so special about levofloxacin? I can't hear you. I'm old, remember? So you want gram-negative coverage, right? So if you have a gram-positive versus gram-negative are much more hazardous to the patient. So you want to have like a broad gram-negative coverage. So you start with levofloxacin, not to say that it doesn't have gram-positive, it does, but mostly gram-negative coverage. And then one of the things you want to be careful with levofloxacin is, and I get this day in and day out, is you send in a prescription and inevitably I get a call from pharmacies like, hey, patient, you ordered levofloxacin. We want to make sure that you're aware of QT prolongation. And especially for some of our patients that are on other medications, which we'll get into drug-drug interactions. So you have to be careful. Make sure that you have, baseline EKG. For all of our patients, obviously, they would have had an EKG done. But in general, even if they're not transplant-related and somebody is on levofloxacin, you want to be aware of the QTC prolongation. And of course, yes?
Let's just say you have to put a patient on two medications that cause QTC prolongation. There's no other alternatives. Is there a way to predict by how much the QTC will reduce?
Unfortunately not. So they may be okay for a while, and so it's idiosyncratic. It's not dose related, it's not duration related. It can happen. You may be okay with this course, and it can happen at another time. So at that point, you're really monitoring these patients. So you do a baseline EKG, right? And let's say their QTC is already like in the 400s. Well, then you want to be careful. You might want to monitor it more frequently. If you're only putting them on for a week and their counts recover, then that's fine. But if you are expecting for them to be neutropenic for a longer period, then maybe 2 weeks later, you might want to get an EKG and just make sure that everything is doing okay. And then, of course, if patients are allergic to fluoroquinolones and you can't do levofloxacin, there is third-generation cephalosporins that we can substitute for. So just kind of keep that in mind. In terms of antifungals, again, same thing. If they're neutropenic or what we call fresh allo, meaning they're still within they're recently transplanted, you definitely want to cover them for fungal infections. And, the fungal infection can range anywhere from a mold, a simple mold, although mold is never simple, versus like mucor aspergillosis, which are extremely highly invasive fungi that you need coverage for. So you have your azoles, which is the fluconazole, voriconazole, posaconazole, and of course, mycofungin. You have options, and then how do you pick which one? So for our transplant patients, we want to protect them from the most invasive infections, so which are, like I said, mucormycosis and aspergillus. And so right now, as things stand, it's one of the things, is it on the next slide? No, it's not. Cresemba, it's one of our newer antifungals, isovonaconium, I think. Am I saying it correctly? I had to practice it last night, so it's just easier to say Cresemba. So we use posaconazole and Cresemba the most, but again, you're battling with insurance companies, so you're kind of limited to what the insurance will cover. And, or, if they don't, then you submit letters to say, hey, you have to fight for your patients and then try to get this. But in terms of posaconazole, it has good coverage for aspergillus and mucor, but again, drug-drug interaction with posaconazole is extremely high with the CYP inhibition, so you have to be aware of that. Dose adjust medications. Voriconazole has some aspergillus and mold, not so much for mucor. So understanding what they're taking, why they're taking, and the side effects. So for you guys, where you come in and we rely highly on Amir, is how, what are we, how do we mitigate the drug-drug interaction? What are we looking for? Can you make any recommendations in terms of dose adjustment? So that's where all of you guys come into play, especially for those of you that will probably go on into oncology/hematology. You're really relied on for the medication recommendations. So PJP is an opportunistic infection for immune-compromised patients, so you definitely want to cover for that. And we typically don't start this immediately because, for example, Bactrim, which is the most ideal medication to use for this, has a lot of myelosuppression, so it can lower your counts. So these patients already are struggling with counts, so we don't want to start them on this right away. We wait for their counts to recover a little bit before we start on it. Usually about a month or so after transplant is when we put them on it, about 3 times a week. So you have to be careful about, obviously, if patients have sulfur allergy, you have to account for that. With Bactrim, you have to worry about hyperkalemia. Again, myelosuppression, they have some GI issues, renal insufficiency. So all of these things that you have to account for. So it's very much a juggling act. So you have to protect them. You have this medication. What's the side effect? What are the things that we're looking at? So it's you're kind of like walking a fine line. So for those that have a sulfur allergy, or in most of our experience, so let's say they're about 5-6 weeks after transplant and they're still struggling with their counts. They're not ideal. Their white cell counts are low. Hemoglobin is still kind of like 8, 8.5. Platelets are still kind of like 50, 60,000. Well, you don't want to start them on the Bactrim and have their counts go down. So what are your options? Well, our next go-to is Atovacone, which is Mepron. It only comes in a liquid form. And about 70% of our patients absolutely hate this medication. It's because it's, for lack of better words, it's kind of like a yellow paint, and that's how patients describe it. It's very thick, it's yellow, kind of like this neon yellow color that they have to drink. It's hard to get down. So the compliance with this is going to be an issue for our patients. So they can't wait to get off of this medication and transition to Bactrim. And unfortunately, for some of our patients that are sulfur allergy, they're kind of stuck with it. Kind of. So let's say you can't give them Bactrim and you put them on Atovacone, and they're not able to tolerate it. They just can't. They've tried every time they take it. They're just throwing up because it's so disgusting. Well, then you have an option of Dapsone. But one of the things you have to be careful with Dapsone is that you have to make sure you're checking these patients for G6PD deficiency, because if patients have G6PD deficiency and you put them on Dapsone, what do you think will happen? What happens on G6PD deficiency patients? Very good. Yes. So now you've taken this cytopenic patient and then put them into hemolysis and made just things worse for them. So you check and make sure that they don't have G6PD deficiency, and if that's all good, then your next option is going to be Dapsone. So this is the order of our preference: Bactrim, Atovacone, and Dapsone. I've recently had one of our providers do doxycycline. Yeah, so I thought that was very interesting. So in terms of viruses, So you want to cover them for HSV and VZV. VZV is your chickenpox virus, varicella zoster. So typically all of our patients after transplant will go on 800 milligrams twice a day. Again, you have to monitor their renal function, make sure that they're hydrated well, because this is definitely a very nephrotoxic medication as well. And if they have renal compromise, you can adjust it based on how bad their creatinine clearance is. For some of our patients that can't tolerate acyclovir, another option is valacyclovir. We have a couple of patients on that. Usually with acyclovir, they'll complain of headaches. They're just not able to take it. And it's not frequent, but I did have to switch a couple of patients from acyclovir to valacyclovir. So valacyclovir comes in 500 milligrams. Acyclovir is 800 milligrams. It's still BID dosing. Letermovir. It is an antiviral that's very specific. It's FDA approved for CMV prophylaxis. So it's not for treatment, but it's for CMV prophylaxis. So I think initially, Amir, when you're looking at the donor matches, one of like the age and then what match and all of that, one of the things that we also look for is their CMV status. So if a donor is CMV positive, and then the recipient is also CMV positive, so we have to make sure that they go on letermovir to help prevent CMV reactivation. Because CMV, again, is an opportunistic infection, so it has several implications. It can cause ocular issues, GI issues, pulmonary issues. It can make their counts go down, so you definitely want to protect the patients from CMV. You also do letermovir if, actually, I think the indication is if the patient is CMV positive, for sure you put them on. But here we do regardless the donor. So if a patient is positive and the donor is negative, that's where it's indicated. But at our institution, either or we do. The only time you don't put patients on letermovir at our institution is if they're both negative, which is about 20% of our cases have that situation. Most of them either or will have a CMV. If I were to check all of your CMVs, about 80% of us will have CMV positive for us. Again, letermovir is not for treatment. It's only for prophylaxis. So typically, they recommend that you start around day 8, but here we do it a little bit later, and we continue our patients through day 100. The side effects from this is also, again, it's a CYP inhibitor, so you do want to be careful about the drug-drug interactions. It can be given IV or PO, but a lot of times our patients are on just PO. It comes in like a package 20-day supply, and then they take it through day 100. Now, does that mean that once they're on letermovir that they don't have CMV reactivation? Absolutely not. It's about 60-70% effective. So there's still patients that are at a risk for a CMV reactivation. So as part of our monitoring, when the patients come in and see us, each time they come, they get their counts, their renal functions, their liver functions checked, but we also check for their EBV and CMV every time they come because we're monitoring to make sure that there's no reactivation of these viruses. Yes? So the first day, inpatient, do they typically start them about day 8 to 10, like the acyclovir and stuff?
We start them right when they get it.
Oh, so even on the day 0, they... Oh, okay. Oh, okay. Okay, yeah, because I know some of them, they delay them up until they're a little bit of an engraftment, depending on when they engraft. Okay. Mm-hmm. Oh, also another thing is that for some of our patients that have had indication for myelofibrosis, right? So for that, there's a lot of spleen involvement. And in the past, we used to do splenectomy, which is no longer recommended, or even spleen radiation, which is also not done so much. But for those patients, you do want to have protection for encapsulated, because the spleen is what protects us from the encapsulated organism. So you need to be aware of that, and how are we protecting those patients from infection. And as part of the workup, if patients have had in the past a hepatitis, and then you do their titers or you do their workup, and then there's a potential for reactivation, you also want to protect them with entecavir that we throw in as part of their anti-infection medications. And entecavir, they actually stay on it for about 6 months after they go off of their immune suppression medications. Kind of covered this in the past, earlier on. So they are completely wiped out. They have no protection, no vaccines that they got on board. So down the line, we do give them immunizations, which starts about 6 months after transplant. One of the things that we are really looking for as part of the post-transplant evaluation is graft versus host. So when patients are consented for allo transplant, one of the things that we really spend a lot of time is on graft versus host. And if you kind of picture yourself being a patient, you've had chemo, you're tired, you're getting ready to go through transplant, and everybody's throwing information at you left and right. And like right now, when I or Amir and Brian are talking about all of these things, for some of you, it might seem like it's like such an overwhelming information, right? Like all of these technical terms that are there, new words that you haven't heard. But now think about the patient that probably does not have any medical background. Most of them, some of them do. It's a lot of information. So when we talk about graft versus host, it's just one of those things that just kind of goes out their thought process, because all they hear is transplant and survival. The side effects associated with it kind of take a back seat, because it's like, it doesn't happen to me. I'll be okay. I just want to get through transplant and be done with it. So we kind of have to constantly remind them of it, because graft versus host is a real thing. 30% of our patients at some point will have graft versus host. Now, it may be mild to moderate, but about 15% of our patients will have moderate to severe graft versus host. So, it can come in the form of skin, GI, where they have nausea, vomiting, diarrhea. It can come in the form of lung infections, pulmonary implications, liver. When we monitor their liver, we're looking at, their LFTs are elevated. Well, why are they elevated? Could it be because of medications that we're giving them, like posaconazole that has, hepatotoxicity, or is it Cresemba because of its liver issues, or is it graft versus host? So graft versus host is always a differential diagnosis in the realm of a transplant patient. In terms of vaccines, I said 6 months is when we start them on their routine vaccinations. But if it's been at least 4 months since their transplant, we do recommend all of our patients get their annual flu vaccine if it happens to be in the flu season that they recently had transplant. And now with COVID too, we do recommend that they get the COVID vaccine, but we always want to make sure that their platelet counts are okay before we say okay to get a COVID. Because there's lots of reports that with COVID vaccine, it can cause thrombocytopenia. So if you have a patient that's in the 30s and 40s, we say, okay, hold off. You can get your COVID booster once your platelets are a little bit better. I'm not going to spend too much time on this. Again, same thing, like, well, you guys don't remember, but they get these vaccines, 3 sets of vaccines, 3 months apart, more or less. They can be anywhere from 2 to 4. So you do the same ones, like Haemophilus, you do hepatitis, polio, DTaP, pneumonia, meningococcal, all of those vaccines. In the past for pneumonia, we used to do pneumococcal PCV 13, but now that we have Prevnar 20, it's just a one-time dose that we do, and we don't have to worry about it. In the past, they used to get 3 of the 13s and then followed by the 23. We don't do any live vaccines for these patients up until 2 years after transplant. So the measles, mumps, rubella. What's another live vaccine recently that's approved that we should avoid? I heard it here somewhere. Varicella, yes, very good. It is a live vaccine, but I think the days of you have somebody having a varicella reactivation is going to be low because all of us here have been vaccinated. Like the baby boomers still have that potential for getting chickenpox. The odds of us getting chickenpox is very low. But yes, varicella is definitely a live vaccine. There's another live vaccine that recently got approved. Yes, RSV. So be mindful. For patients that have MMR that they need to get, so we have patients that are mothers, fathers, grandparents that take care of little kids, and they have a year-old that's getting their live vaccines. We do caution against them exposure. So we say, hey, if your son, daughter, niece, nephew, grandchild is getting a live vaccine, in terms of your exposure to them, just, we say about a week for it to get kind of cleared out. So don't change their diapers. Don't be around them if you can. As a parent, it's hard to avoid, but we say, wipe them properly, wear gloves, have somebody else change diapers, whatever precautions you have to try to limit yourself for that 1 week once they get their live vaccines. So graft versus host, again, it's essentially the donor cells reacting with the body organs. So they see it as a foreign body. So there's T cell proliferation, interleukin release. So it's a lot of battle that happens between donor cells and the recipient cells at the organ level. So again, like I said, skin is the most common place where graft versus host presents itself. It usually presents in the form of a rash. It's extremely itchy. Liver, GI, so they have nausea, vomiting, diarrhea, and this diarrhea can be large, watery stools. Nausea where they just can't eat anything. Poor appetite, or they're able to eat but very little. They fill up very quickly. So a lot of manifestations of graft versus host. So for example, for the skin rash, it kind of looks like, with the maculopapular rash is how it's described. So it's usually just very localized. Sometimes it's only the face, sometimes it's the hand. So just kind of like the burn way of accounting for percentage. That's how we quantify our skin rashes also. So we say, face 9%, arms 9%, legs 18%. Up the front of the trunk is 18. So all of this kind of adds up to 100%. So if it's local, like, if you have some rash on your hands and, it's less than 25% or so, you can just do away with some topical steroid creams. But if it's more than that, we'll get into how we treat the graft versus host from a systemic perspective. So with liver, usually they're not going to come and tell you any liver symptoms per se, although they might have some abdominal cramping, but it's reflected in the liver function tests. So acute, usually within the first 100 days of transplant, loosely is considered acute. Anything beyond that is chronic. Now, can graft versus host occur at any time after their transplant? The answer is absolutely yes. You can go on for a year or two and all of a sudden develop graft versus host. Usually those things tend to be skin changes where the skin becomes like very thick, leathery. It's what we call scleroderma. Or from a lung perspective, they feel like, hey, you know what, I'm having issues climbing up a couple of stairs. When I go on an uphill, I feel like I'm short of breath. I need to take a break. Or I feel like, when I'm walking, my joints, they just ache so much, or my muscles hurt so much. And some of these symptoms can be so vague, it's really hard to narrow it down, partly because there's no test, there's no markers for us to run some blood tests and say, yes, this is graft versus host. Because if you do blood tests, markers like CRP, sed rate, all of these are just, in general, inflammatory markers. They're not specific for graft versus host. So how do we treat our patients from getting graft versus host? How do we suppress their immune system so that way the donor cells can go in and get embedded and not create issues, so that way they have this long durable cure? So some of the medications that we use are tacrolimus, sirolimus, mycophenolate, methotrexate, ATG, cyclophosphamide. So all of these are medications to help prevent graft versus host. So the last one, the PT-Psy, is actually part of our conditioning regimen now that we use to help. So it's not they don't get it after, once they're done with transplant, which is kind of true, kind of not true, but in general they don't. They get it as part of the conditioning. Most of these patients are discharged home on mycophenolate for about a month or so. Tacrolimus, they're on it for a little bit longer, and sirolimus a little bit longer also. Now, these immunosuppressants obviously are used in the whole realm of oncology. These are not just hematology specific. If you look at solid transplant patients with either kidney, liver, lung, or whatever, they are on immunosuppressants for the rest of their lives. Allo transplant patients are not on immunosuppression for the rest of their life. We do take them off of these immunosuppressants more or less anywhere from 4 to 6 months after transplant, depending on what complications they have or don't have. So tacrolimus is considered a calcineurin inhibitor. Essentially, it, again, T cell proliferation with the interleukin release, and with the interleukin, it kind of goes through a whole cascade, and then it inhibits the calcineurin, which has to do with the calcium. It's an extremely complex mechanism of action at a very cellular level. And trying to explain this to a patient is going to be that much harder now that we ever have to. But there are some patients that do want to know what medications they're taking and why. But essentially, we just say, so most people will understand the immunology in a sense that it's your cells fighting against, the donor cells fighting against your own cells. And there's some markers that are released, and it targets one of those to help prevent the, so it kind of keeps the host cells down so they're not attacking. So tacrolimus is widely used. One of the things that we do have to worry about it is, again, it is a CYP inhibitor, so you have to be careful about drug-drug interactions. Renal nephrotoxicity, you do have to monitor patients for their kidney function. You have to monitor their levels. So there's a nice range that you have to monitor. You want to keep them in about 7 to 10 is the range that we want. So you adjust the dose depending on what the levels are. Sometimes if the levels are too high, patients will have tremors in their hands. They feel very restless. And at some point, for patients on tacrolimus, we don't recommend that they drive because of this thing called PRESS. Posterior reversible encephalopathy syndrome. So they have like all kinds of neurological issues associated with it. So you have to be careful with that. So patients, we say, hey, somebody has to drive you. They can drop you off and pick you up, but we don't recommend that you drive. So a lot of things that you have to keep in mind. It can also elevate your blood sugar. So we monitor our patients for that. So you have to educate your patients on that, especially if they're diabetic. Just let them know, hey, you're on tacrolimus, your sugars may be a little high. Tacrolimus also depletes your body of magnesium, so these patients are on magnesium supplementation. Magnesium, again, you give them the magnesium, you're trying to kind of keep it at a level about 1.5 to 1.8-ish. The more magnesium they take, what happens when you take too much magnesium? I'm sorry, what? I think I heard diarrhea. Milk, Phillips milk of magnesia, right? So it's the same concept. These patients will complain of saying, hey, I'm having some diarrhea or soft, mushy stools. So as part of our education, we say, hey, if you are having this, it's because of magnesium, and you're taking magnesium because of the tacrolimus. So as you can see, like how everything kind of fits in, you have to keep an eye on every little aspect of the medication that they're taking, drug-drug interactions, side effects. How do you mitigate the side effects? And what's the fine line? What's the risk versus benefit? Sirolimus is another immunosuppressant. It's not a calcineurin inhibitor. It is an mTOR. It does the same thing, but just the where it keeps the immune suppression is at the mTOR, which is mTOR stands for mammalian target of rapamycin. That's the target where it works at. Same thing. You're still monitoring the levels. You want to keep it at a therapeutic level. We kind of want to keep it around 4 to 5 range. 12 is too high. We never keep our patients at 12. They're usually about 4 to 5 range. It also is another CYP inhibitor, so a lot of drug-drug interactions. Hepatotoxicity is an issue, so you have to keep an eye out for their liver function tests. Nephrotoxicity can cause issues with interstitial lung disease, so you want to be monitoring patients for any pulmonary symptoms, shortness of breath, coughing, difficulty breathing, so on and so forth. Mycophenolate CellCept is another, it's an anti-metabolite that we use for immune suppression. The most common side effects associated with CellCept is GI. Patients sometimes have severe abdominal cramping, diarrhea, nausea, vomiting. Thankfully, our patient population is only on it for about 35 days after transplant, and some of the patients can't wait to get off this medication. So initially when they come in and they're having this nausea, vomiting, diarrhea, and you're thinking graft versus host, and you kind of do their med review, and if you notice that they're on CellCept, that's probably what's causing their nausea, vomiting, diarrhea. And sometimes if it's significant enough that they're having so much of nausea or GI issues, and if it's close enough, let's say they're about 30 or day 32, sometimes we're comfortable taking them off of it just because of the severity of the GI issues that they have. Methotrexate, again, another autoimmune modulator, right? Because it's usually its origin started with the rheumatoid arthritis and stuff, but we use it definitely for GVH prevention, usually part of our conditioning regimen for some of our conditioning protocols that we have. Again, renal adjustment, nephrotoxicity, you want to give them leucovorin, you want to get it out of the system, you want to check their level to make sure it's out of the system. Patients will have mucositis, GI effects associated with it. Again, another one of these that has pulmonary effects if taken over prolonged periods of time. And it can cause myelosuppression, delaying some graft delay. So how do we treat our patients with graft versus host? We have a whole toolbox of medications that we use. Of course, keeping their immune system from not acting up is one way with the medications we talked about. If it's skin GVH and it's limited, just kind of like a small amount of rash, topical steroids. But if they have a large involvement, so let's say it's more than 50% of their body surface area, then you do want to use systemic medications. Of course, steroids are a mainstay if they're the first line of medications. You always want to make sure that their tacrolimus or sirolimus that they're on, their levels are in therapeutic range. And then you always want to make sure that they're on protection for antifungals, antiviral, antibiotics, and so on and so forth. Now, we have some patients that have either steroid refractory GVH, meaning you've put them on steroids, they've been on it for a couple of weeks, you're tapering them off, and then at some point, so let's say they are at 80 milligrams of prednisone, and over a couple of weeks, you've tapered them down to 40 milligrams, but then they showed good response, but as you lower the steroid, then their GVH flares up. Then what do you do? So we have other kinds of medications that we use, Jakafi or ruxolitinib, which is a JAK inhibitor that's used for chronic and acute and chronic. We have belamozidil that's probably in the market for 2 years now, just about. And the other two, basiliximab and infliximab, we don't quite use those so much, although abatacept, we do use it now for some of our conditioning regimens. And it's not just taking out one and then substituting the other. So by the time patients have moderate to severe GVH, they need all the help that they can. So they are on tacrolimus or sirolimus. They are on steroids possibly. They are on Jakafi. They are either on belamozidil. Now, there are some institutions that are actually combining Jakafi and belamozidil, or ruxolitinib and belamozidil. And then they have, we actually didn't go into it here because it's not a medication per se, but some of our patients are on photophoresis to help with their graft versus host. Graft versus host can be a very debilitating thing. So you're essentially now taking their very reactive immune system, completely shutting it down, opening all the doors open for all kinds of infections. So allogeneic transplant patients, it's great that they have a potential for cure, and some of them do really well and go on to living happy, healthy lives. But there are a few, probably about, again, 15 to 20% of our patients that struggle with graft versus host. Their quality of life is impacted. Their immune system is very much shut down, and a lot of these patients, they don't die of cancer or the transplant. They die of complications of graft versus host, which is infection, is what kills them. Same thing, we talked about Jakafi. One of the things you want to be careful with JAK inhibitors is their ability to suppress the counts. So with ruxolitinib, we do worry about their counts. If the patients have GVH and their counts are low, we're very wary of starting them on Jakafi because it can lower their white cell counts, platelets, and so on and so forth. You have to adjust the doses. So let's say the indication is 10 milligrams twice a day, but their counts are low. Now you are adjusting it, and then let's say they can only tolerate 5 milligrams twice a day. That's fine, but how effective is it that you've dose reduced them now by 50%? Although now there are some studies that are coming that 5 milligrams twice a day is probably just as effective as 10 BID. So if you can mitigate the side effects, you can, but sometimes you're just not able to, and that's not enough. So then what do? Then we're like, oh, okay, let's try Rezurock. But from my personal experience, between Jakafi and belamozidil, Jakafi works a little bit better in terms of controlling graft versus host. But if I have no choice and the patient's counts are low and I have to come up with an alternative, Rezurock does pretty well for some GI and skin issues. I haven't seen much luck with pulmonary issues. But one big thing with belamozidil is the hepatotoxicity. So you really, really, really do have to be careful with that. So we've had a couple of patients actually ended up with amylase and lipase elevations also. So questions?
Okay, so you can all open up the quiz now for BMT, and we're going to go through the cases that answer the quiz. These slides, so these case slides are not uploaded yet. They'll be uploaded in about an hour because they have the answers on them. So they'll be uploaded shortly.
Yes. For these patients with graft versus host, when do you decide when to stop? Great question. So typically these patients stay on immunosuppression medications about 4 months-ish. And so for some of our patients where we want the graft versus leukemia effect. I think Brian alluded to that. Like our AML patients, right? You want the graft versus leukemia effect wherein you want the donor cells and the immune modulation to actually attack any possibly remaining leukemia cells. If you want to have that effect, you want to take them off of the tacrolimus or the immunosuppression medications a little bit sooner. But you have to make sure that they don't have graft versus host in any shape or form. So if they have active graft versus host where they are needing systemic medications, then you kind of delay when you take them off of the immunosuppression medications. But if everything is going according to the textbook and they're everything great, you do their day 100 bone marrow biopsy, which shows that they're in continued remission. And their counts are good, their white cell counts, platelets, everything looks good. And then one of the things that we also check for is what's called chimera, which is looking at their donor cells to see what percentage of their cell lineage is from the donor and which is from the recipient. Ideally, after a transplant, you want to see 100% of their cell lineage to be of the donor and not of the recipient. So if all of those are, all the check boxes are in place, then you can slowly start taking them out, tapering them, so you don't just go from tacrolimus of 3 milligrams twice a day and then just yank them out. You have to slowly taper them off. So we don't have an exact timeline, but it just depends on their diagnosis, how well they're doing, what their counts are, and then we take them off. Usually by 1 year, most of our patients are off of the immunosuppression medication. Okay, so we're going to do a case study. 54-year-old male presents to the hospital ED late at night, severely dehydrated with over 2 liters of diarrhea per day for the last 3 days. His hematologist is very far away, so he's complaining of weakness, dehydration, again, large volume diarrhea. And then the patient's medical history is they recently had allogeneic transplant, their AML, they're a little over a month out of transplant with a history of hypertension and chronic kidney disease. So you're on call. The ED doctor calls you overnight to help interview the patient, look at their medications, and which of these, if any, are related to contributing to the patient's problems. So what do you guys think is happening here with this patient, just based on what we've talked about? Okay. So how do you come up with that? What is it in here that makes you think that it's graft versus host? Okay. So weakness, dehydration, and diarrhea are all, yes, definitely graft versus host is a differential. But also remember, dehydration can be just because patients are not drinking enough fluids, by innately. Maybe they're in Bakersfield and it's 200 degrees and they're just not drinking water. So that's number one. And number two, some of these things are not that easy, right? Like it's easy to say it's graft versus host just because we've kind of talked about it. So don't have this tunnel vision. Expand your horizon. There's so many things that could be happening with a patient. It could be, drug-drug interaction. It could be graft versus host. It could be maybe they just have a flu, something else, like a acute gastroenteritis. So just kind of keep all of those things in mind. But yes, because we're talking in the context of this, yes, graft versus host, and then we'll talk about why. So you talk to the patient, and these are the medications that the patient is on: acyclovir, Bactrim, posaconazole, and letermovir. So which of these medications, so what's coming to mind when you look at this medication given patient's history? And they're also on tacro and sirolimus. So infectious disease has been ruled out. So they were given hydration, electrolyte replacements for severe dehydration. So we kind of jumped to the conclusion. Yes, we said it was graft versus host. So what should the pharmacy assess for? Why do they have graft versus host? So remember we talked about tacrolimus and sirolimus. We need to maintain some serum levels, right? So if they're not in the therapeutic range, then they're not getting that immune suppression, appropriate immune suppression to keep the donor cells from reactivating and causing the graft versus host. So you always want to make sure it's part of the blood work. Oh, patients are tacrolimus. Well, what's their tacrolimus level? Oh, sirolimus. What's their sirolimus level? Are they taking their medications? Maybe they're not taking, the tacrolimus comes back and it's, I don't know, less than 2. Are they taking the medication? Because these patients have a lot of medications. Are they taking them on time? Are they taking them all? Do they understand why they're taking these medications? Drug-drug interactions, right? So they're on posaconazole, they're on tacrolimus. What are the drug-drug interactions? Do we need to adjust? Maybe their tacrolimus levels are out of control, and then that needs to be adjusted. So you always have to kind of keep those kind of things in mind. Other related toxicities, is posaconazole causing any of the GI issues, or letermovir? Letermovir can cause some GI issues. So is it that? Do we need to take them off of it? So a lot of potentials here. So how do we manage their medications? So it turns out they went on a trip, they haven't been taking their medication. So that automatically gives us the adherence, understanding the importance of taking these medications in a timely manner. So because they went on a trip and forgot to take their tacrolimus levels are extremely low, less than 2. So which kind of makes us think that, okay, this is graft versus host. You need to, so in this case, and I'm going to, you would probably, if they're having such large volume diarrhea, they're so dehydrated, you probably want to admit them, load them up with tacrolimus, make sure that they're on therapeutic levels before the patients are discharged. So this is another part B. Patient was discharged after short admission with a resolution of diarrhea because we kind of got them back on their tacrolimus levels and so on and so forth. And 5 days later, he returns to the ED with severe headache for 2 days, tremors, nausea, and vomiting. Again, you were consulted and you were asked, hey, review the medications and tell me what's going on with this patient. So just based on what we talked about, the severe headache, tremors, nausea, vomiting, what do you think is going on in this case? I'm sorry, what? Yeah, so remember we talked about tacrolimus. When the levels are too high, it can cause tremors. So you did the blood work, patient is on, because of the possibly the drug-drug interaction, the tacrolimus levels are high, it's 22, extremely high. Patients will definitely have symptoms at this point. Headache, tremors, feeling restless, some lethargy, nausea, vomiting, all of those things are fair game. You might want to check their kidney function because tacrolimus is extremely nephrotoxic. So with the level of 22, you want to check and see what their serum creatinine levels are. Maybe they need hydration, so on and so forth. So always keep that in mind. So you hold the dose. So typically, and this is what we do for our patients, we tell them, hey, after you had your levels drawn, we'll get them in a couple of hours. When the levels come, we'll call you. And then inevitably, we make these calls day in and day out. So the tacrolimus levels sometimes for our patients are high. And most of the time, it's because they forgot to skip the morning dose before their blood draw. So technically, they take their dosing AM and PM, and they come the next morning and we draw their levels. So they're supposed to hold their morning dose until after the blood draw. Sometimes patients forget and they take it. So when we get those high levels, we call them and say, hey, did you take your medication? They're like, no, I didn't take it. I held it. You told me not to take it. Perfect. So then their levels are high, so we have to adjust it. We don't always bring patients in to get admitted if their levels are high, depending on their symptoms. So if it's 22, we say, okay, skip your morning dose, evening dose, and then you resume at half the dose the next day, and let's have you come back for levels in a couple of days, and then recheck to make sure that they're doing okay. But if their kidney level is really high, we do bring them in for daily hydration and take care of them outpatient. So when you do notice a drug-drug interaction, it's okay to hold some of the medications, but if you have to hold them for prolonged periods of time, then you do need to entertain what other alternatives you can put these patients on. So again, the posaconazole was held, tacrolimus was held, you recheck their doses, and then you can re-challenge them on posaconazole and continue to monitor their levels. Another 56-year-old with AML in first remission had a haploidentical transplant with fludarabine and radiation as part of their conditioning for the transplant. So this patient received mycophenolate, tacrolimus, and again, post-transplant, what we call PT-Psy for graft versus host prophylaxis. She is seropositive for HSV and CMV, and the donor is also seropositive for HSV and seronegative for CMV. So they're allergic to sulfa medications, and on day 9 of the transplant, her ANC is decreased from 900 so to 300 something, extremely thrombocytopenic with the platelets of 12,000. They're not febrile, vital signs are pretty stable, and you're reviewing their medication summary, and you find the following listed as anti-infectives. So they're on acyclovir, levofloxacin, letermovir. What type of infection prophylaxis is she missing from her supportive care plan? Yeah. Very good. Because the patient is, if you look at it, they're on ANC of 320. So we have them covered with acyclovir, which is antiviral. Levofloxacin, again, for that neutropenia prophylaxis. Letermovir, because the CMV is seropositive. You have them covered on that. And yes, antifungal is definitely a must that they need to be on. So the care team recommends, you're like, hey, they're not antifungal. And then, so yeah, sure, let's add posaconazole. What are some of the safety aspects to consider before starting posaconazole? QTC, yes. It's a strong CYP inhibitor, yes. Make sure that their liver functions are good. Interchangeability in terms of IV to PO, is that what? Brian, what's the interchangeability here?
There isn't like a direct interchangeability between formulations.
The IV and the PO, right? Okay. Yeah. So, they're day 28. Again, like I said, we also cover patients for PJP prophylaxis. So you're reviewing patients' discharge medication, and notice that Bactrim was ordered for PJP prophylaxis. What are some medication safety concerns with Bactrim that we talked about? Yes, sulfur allergy, absolutely. What else? Yes, myelosuppression. Their kidney function, so you want to make sure that their renal status is good, any issues with hyperkalemia, all of those things. All right. Any questions about anything we talked about? Graft versus host, medication, side effects, anything? All right.
Okay, thank you very much,
All right, thank
Lakshmi.
you guys.
So it looks like the slides were already posted, so that should have been an easy quiz for you guys. So if you haven't done so, you can download them, submit that quiz. There's going to be a second part of the quiz for CAR T. So take a quick 3-minute break, and we'll get started with the last portion. The quiz question, we'll answer it right after the break. Okay, we're going to go ahead and get started, everyone. For your quiz, if you submitted it already, let us know and we'll adjust it, but there's some questions on it. So for the first question, patient case 1, there's different answers that are applicable here. So if your free response contains reduced renal function or clearance, drug-drug interactions, or DDI, nephrotoxicity, renal toxicity, any of those should be fine. Should be the fill-in-the-blank question. Oh, sorry. Actually, the first one, sorry, so that one, patient case 1, the 54-year-old male. So that one, tacrolimus or sirolimus levels, medication adherence, tacrolimus/sirolimus. Okay, we're going to review these quiz questions also, just to make sure it was applicable. And then from the second fill-in, DDI, reduced renal function or clearance, decreased renal function, renal toxicity, renal insufficiency, any of those work. You just put one of them. First question, 2. We're going to review these questions. So if there's a concern, please let Eugen know. He's the TA for this module. Okay? And then there's a question number 6. Today is day plus 21. The answer is sulfa allergy. Okay? Sulfa allergy. Yes. I can't hear. QT prolongation and strong CYP3A4 inhibitor. So typically for these questions, quiz questions, we usually have our lecturers go through it in class. So if you have any issues with your quiz, please reach out to the TA for that module. You can email them now or after the course. Okay? Any other questions before we get started? Antifungal prophylaxis for number 4. Okay? But these most... We'll review it. Okay? Sure. Stick to 1 if you haven't submitted it yet, but we'll review it. Okay? Well, for these small quiz questions, we'll discuss them after class. Okay? So after class, you can come to your TA, and then we can review your quiz. All right, so we're going to move on now to the CAR-T portion. Okay, so don't worry about your quiz, guys. We'll fix it if there's any issues. Okay? So we're going to move on to the CAR-T portion of this lecture. So very excited to invite Dr. Wei, who's also from City of Hope. She may be herself or Dr. Lee, one of your preceptors at City of Hope, if you received a rotation block there. So she brings a wealth of knowledge surrounding cellular therapies and focusing on CAR T today. So thank you, Dr. Lee.
Thank you. Hello. Hi guys. Can you guys hear me? Yeah? Everybody in the back can hear me? Okay, awesome. Okay, hi everybody. My name is Shannon Wei. I graduated from USC. I'm a USC alum. Go Trojans. So I actually did my PhD before going to pharmacy school. So I was working at Norris Cancer Hospital at a cancer research laboratory. During my PhD, because I was like so intrigued about cancer, immunotherapy, which led me to go to pharmacy school, and then I did my pharmacy school here at USC as well. So I sat in the same seats that you guys are here now, and it's so wonderful to be back in this classroom. Okay, so I'm currently a clinical pharmacist at City of Hope. I work primarily with the Kaiser team, working with cellular therapy patients, which include the transplant patients that we just talked about, and I also take care of CAR T patients too. Okay, so I have no disclosures. Learning objectives, these are the learning objectives that I want you guys to know, so review them. And the test questions are gonna be focused on the learning objectives, okay? So let's start with some introduction. Okay, to start out, we're gonna talk about engineered T cells. So engineered T cells is a relatively new concept, which entails a combination of three basic concepts. Okay, first one is antibodies. We all know antibodies provide that specificity, right, for you to target a specific protein, usually, in the system. So it utilizes the antibody concept. It also utilizes what we call vaccination. Vaccination, in this sense, we're not really thinking about giving a shot, but vaccination in the sense that this cellular therapy is going to awaken your host innate immunity. Okay, so innate immunity awaken, acquired immunity awaken, awakening immunity. Third concept, it includes transplant, which along the same lines, transplant. We're using the platform of a living cell. So with that being said, what are CAR T cells? Here in this room, how many of you have heard of CAR T cells? Okay, wow. So I gave this same lecture last year, and then the number of people was not as much as right now. So I think it's definitely growing growing a lot of tension, because now we're seeing more and more CAR T cells, and you guys are gonna find out why. So what are CAR T cells? Okay, CAR T cells are basically exactly what it sounds. You have a CAR, and then you have the T cells. Okay, so what is the CAR? The CAR, I'm gonna go over the design in a little bit. The CAR, essentially, it stands for chimeric antigen receptor. Chimeric antigen receptor, so that's a gene that is gonna be introduced, it's a genetic construct that's gonna be introduced to the T cells, and it's kind of like a Frankenstein-ish like T cell receptor. It's a genetically modified T cell receptor. And with this chimeric antigen receptor, it has the properties of the antibody. So it's able to hone in to a specific target, which we're going to say on the cell surface of the cancer cells. And these CAR T cells, because it has that CAR, it's going to hone all these CAR T cells into the body and find those cancer cells that have that specific target. It brings it in, and then it's going to destroy the cancer cells. So it just gives that extra specificity and selectivity. Okay, but like before we talk about CAR T cells, so these are CAR T cells, genetically engineered T cells. Let's first understand what is the basic physiological T cell receptors. Did we have our immunology class already? Kind of went over T cells? Okay, perfect. So as you know, probably in your immunology portion of it, they already said that T cells actually require two signals. So the first signal for full T cell activation, you need that first antigen presenting cell through the MHC construct. It presents a peptide, And this together is recognized by the T cell receptor. And then this activation, this link here, provides the first signal. Then it also, for full T cell activation, it actually requires a second signal. Second signal is what we call a co-stimulatory signal. The co-stimulatory signal here, depicted by this graphic on the right hand, is the CD28. So there's more than one co-stimulatory signal. Here is just this figure is representing CD28 was one of the more common ones used. And this is also, this interaction here represents a second signal. So with physiological T cells, you need both of these signals together to activate the full T cell signaling pathway, full T cell activation, downstream proliferation. All of that signaling cascades originates from these two signals. So now we're going to talk about the CAR. So the CAR design, this chimeric antigen receptor, actually utilizes that same T cell receptor construct, but it just picked out the most important part, the signaling transduction part, which is this zeta chain here, okay? And then they utilize the antibodies construct. They utilize the variable portion of the heavy chain and the light chain. So you take those two parts, you link this all together, and then that creates your CAR. So now you see you have your signaling pathway from the T cell receptor. It's linked to the antibody, so that gives you that specificity. And then you have your CAR construct. And that kind of created the first generation CAR T cells. So those three aspects were basically the main first generation CAR T cells. However, they noticed when they were doing this first generation CAR T cells, they noticed that these CAR T cells were working. It went in the body. It actually did target the disease, but they were relatively short-lived and didn't really persist as long as we were hoping for. So after that, they were like, let's think about this. Let's introduce now, with this CAR construct, we're going to add in the co-stimulatory factor, which is that second signal that we were just talking about, to give that full activation. So starting from the second generation, the construct now includes a co-stimulatory domain, and that gives that CAR T cell that fully robust signaling now. So all of the commercially approved, currently FDA commercially approved CAR T cell products are actually all based on this second generation CAR design, okay? And which is what we're going to talk about later. Later on, there's further with technology, they did more research. There's third generation where you introduce two different co-stimulatory domains. So in this case, they did CD20 and 4-1BB. These are the two main co-stimulatory domains that currently are in study for the CAR constructs. But they noticed right now it's still in clinical trial, no FDA approved ones yet. But it seems like it's pretty comparable to the second generation. Fourth generation, they introduced a different cytokine inducer. So these are more for tumors that have, for more solid tumors that have microenvironment. They use a cytokine inducer, which this one actually produces cytokines when the CAR T cells are activated to kind of help with that microenvironment reorganization. But today, for our lecture purposes, we're just going to focus on the second generation, the FDA-approved ones. Okay, so with that being said, we now know, kind of comparing between the CAR receptor and the T cell receptor, there's some major advantages, right? Because of this CAR T now, it actually bypasses that very first MHC-dependent processing of the antigen, presenting it, because it already has it basically already bypasses that entirely. It also bypasses, starting from the second generation, it bypasses the co-stimulatory factor as well because it's already built in. And also for this, it actually recognizes, depending on what the antibody recognizes, it can recognize not only proteins, which physiological T cells can only recognize protein, but now it can basically recognize a non-protein as well. So these two antigens are the two antigens that we're going to talk about in the class. The FDA-approved ones are either against CD19 or BCMA. So CD19 is a cell surface marker. It is the immunoglobulin biomarker that's widely expressed throughout the physiological stage of B cell development. So when you're picking a tumor marker, basically, you want to pick something that's universal, that should be universally expressed on your targets. And then with a lot of the B cell malignancies, the CD19 would be a good one, and which is what we've been seeing a lot of actively studied for that reason. For the other second one is called BCMA. Now, BCMA is a tumor necrosis factor. This one is also highly expressed in more of the mature lineage of the B cells, and then more specifically, more the plasma cells, which is the cell of origin for the multiple myeloma. And this is just for your reference, basically for you to kind of appreciate why they chose these two targets. The CD19, as you can see, there's high expression from pre-B all the way to the plasma cells. And then this is kind of like the cell of origin for these specific B cell malignancies, including B cell lymphomas, Hodgkin lymphomas, B cell ALL. And then BCMA is more expressed towards the later phase, more differentiated phase of the B cell malignancies, and which is mainly the plasma cells. That is the origin of for the multiple myeloma cells. Okay. Then talking about CAR T cell production. So CAR T cell production. Now this is actually a very extensive, long process, as I'm going to go through. So let's start from the top. So it kind of starts with apheresis, leukapheresis, kind of what we were talking about when we were saying be the match, that apheresis. So similar to that, they will basically isolate the white blood cells from this patient. You take these white blood cells, they select and filter out the T cells from that. After they pick out the T cells, then they use usually it's a viral construct, like a lentiviral or retroviral construct. It'll introduce that CAR gene. Okay, so we have the CAR gene here. It'll introduce this CAR gene, and it transfects this T cells. Then this CAR construct then gets genetically integrated into the genome of the T cell. Now this T cell is now a CAR T cell. And then the CAR T cell, because it has this construct in the genome, it'll translate into that CAR, and then it'll go to the cell surface and then express on the cell surface. And now these CAR constructs are now on the surface of the CAR T cell. So now you're going to have these CAR T cells already, and then they further expand the number of these CAR T cells in like this petri dish, essentially. You give it like growth factors to kind of stabilize it, and then provide that perfect environment to kind of grow even more. Once we get enough of these like CAR T cells, we notify the patient, and then the patient's like notified, to come, and then we're going to go through what we call a conditioning regimen, just kind of like how transplant, we just talked about that. They undergo conditioning regimen. For CAR T cells, you also go through conditioning chemotherapy regimen. And after they get that conditioning, then they get the CAR T cells. So this is the entire cycle. So usually this process of like making these CAR T cells, they're typically like 3 weeks or so. And as you can see, it's very extensive, and because it kind of goes from the patient then to the lab and then back to the patient. Okay, so once these CAR T cells are in the body, when they recognize the tumor cells, this you do not need to know. It's just to illustrate the fact that once these T cells are activated, it undergoes a cascade of signaling transduction pathways, and it results in T cell proliferation, T cell activation, a bunch of cytokine releases. And with that being said, since this is such an extensive process and it can cause significant side effects as well, that can be potentially life-threatening side effects that we're going to go through in a little bit. So this is actually regulated through the REMS program. So the CAR T cells are only, oh yes, I have a question.
You said that the T cell activates and proliferates. The new T cells that are regenerating, do they also express the same CAR T receptor?
Yes, that's a good question. So to a certain extent. So some of them, yes, they actually can proliferate with the CAR itself, but then over time, they have their own lifespan and they're going to die off. And that's actually one of the major researches that are currently ongoing, is how to prolong that CAR T cell persistence. Okay, that's a very good question. Okay, so back to the REMS. So it has to be given at a REMS certified facility, and the reason being is, like I said, because they actually can potentially have very serious side effects. So they have, all of the CAR T cell products have box warnings, which are CRS and neurologic toxicities. So this can go from mild to like moderate to very life-threatening severe. So this has to be given at a REMS certified facility. All of the personnel that dealing with the CAR T cells, from administration, from ordering, from verifying, from like everything has to be under personnel that has been properly trained. There has to be an authorized representative. Now, this representative doesn't have to be a certain person, like doesn't have to be a doctor, doesn't have to be a certain degree, like it's just that person has to be properly trained to maintain also the proper training and documents that's reliable for the REMS program. The other thing is, because of these severe side effects that we're going to talk about, especially CRS, it is REMS required that each patient that undergoes CAR T cell, we have to have at least 2 doses of tocilizumab. And tocilizumab, you're going to hear this name a lot later in the second part of my talk. Tocilizumab is for CRS management, and they're required that they at least have 2 doses on site, which is ready for them, just in case they do develop CRS. Okay, so currently there are 6 FDA-approved products. This is the timeline that they are approved in. And then this slide, I want you guys to know. Okay, so do like a star or whatever. So this slide, I don't want you to memorize the actual name, and then so there's a generic and a brand name. You have to know one of them, because on the test it's going to show both. So you can either choose one of the other, right? So like Kymriah, the long name is tisagenlecleucel. Take your pick, what you want, brand or generic. But like sometimes in practice we just say tisa-cel. Okay, so we don't say the entire thing. So Kymriah, this one, the indication for that is ALL, acute lymphoblastic leukemia. But this one of note, it's actually only approved in the pediatric to young adult ALL. Okay. Also, it's approved for DLBCL. And lately, this is the most recent indication that was added just last year, follicular lymphoma as well. Yescarta, this one's also against large B-cell lymphoma, follicular lymphoma. Tecartus is mantle cell lymphoma, and also ALL. Now, this one's the adult ALL, is Tecartus. Breyanzi has large B-cell lymphoma indication. Abecma, so Abecma and Carvykti, both of these are the target antigen is BCMA. Remember that plasma cell, multiple myeloma, highly differentiated, that's the BCMA. So both of these CAR T cell products are for the multiple myeloma indication. Okay. Now, all 6 of these CAR T cell products, they bear the box warning of what we just mentioned, CRS and neurotoxicity. Neurotoxicity specifically for immune effector cell caused neurotoxicity is called ICANS. So sometimes you can see it kind of used interchangeably, but like neurotoxicity specifically for CAR T cells or other immune effector cells, these immune cells are called ICANS. Currently, it's only approved for autologous use. So autologous use means like these cells are from the patient's own T cells and going back to and then genetically modified going back to the same patient. It's currently only approved for relapse refractory indication. So these patients, this is not their frontline therapy because you're going to see a lot of very serious side effects. These are patients that are already relapse refractory post multiple lines of treatment. Then they will consider doing this. However, because CAR T cell has gained so much traction throughout the years, and we've been seeing so much better, robust response in these heavily treated relapse refractory patients, they are gaining a lot of traction. And then for some of the indications, so some products like Breyanzi, that one is actually there's word that we're moving it up in terms of line of therapy. They're talking about like probably moving it up to second line therapy if the patients relapse post first line therapy within a year. So this slide is just to further illustrate and just help you guys kind of summarize. So these first 4, the target antigen is CD19, and it's mainly against those B-cell malignancies that we mentioned. Abecma and Carvykti is against the BCMA. Yes, question. Yes, so these actually, when it's called these names, these are CAR T cells. They're living cells. So they're T cells that are genetically engineered with the CAR construct. So different products have a different CAR construct, essentially. So like say if we talk about like say Kymriah, for example, the target antigen, so the antibody on the top is recognizing CD19 for that CAR T cell, for Kymriah. The co-stimulatory, remember we were talking about these are all second generation ones, so they have the co-stimulatory factor already embedded in it. So for Kymriah, the co-stimulator domain is a 4-1BB. Okay, so for these 2, Yescarta and Tecartus, the co-stimulatory domain is CD28. So it also has that co-stimulatory domain. So, but depending on the product, they might have a different co-stimulatory domain, and but they all have, if it's for a B-cell malignancy, it's all against CD19. If it's for multiple myeloma, it's against BCMA. Is that clear? Okay. Okay. So like I mentioned, so the CAR T cell products right now, we've had some years of experience in clinical trials and actual real life data now that it's been several years. We are seeing that they're providing very good responses. So I don't want you to memorize this. This is just for you to kind of appreciate how effective these are. And so you can see like the CRA, complete response rate, can vary between the products. But like these patients, like I said, these are like relapse refractory patients. So you actually can get these relapse refractory patients to get a complete response rate of, ranging between 50 to like 70%. That's like unheard of. So this like gained a lot of attention. Overall response rate, you can see, has gained like 50 to up to almost 90% of overall response rate. So we talked about there's a conditioning regimen that goes before the CAR T cells. That's what, in terms for the CAR T cells in particular, we call it lymphodepletion. Okay, so this is just a term that we usually use for the chemo preparatory part that we get before the CAR T cells. So lymphodepletion, this is that conditioning, priming series. The reason why we go through this lymphodepleting regimen is that it's been shown that it can enhance the expansion and persistence of the CAR T cells. It optimizes the cytokine levels, and it has, because it's chemotherapy, it has anti-tumor effect as well. And of this, I don't need you to memorize any of the, the doses, whatnot, just appreciate right now the most common lymphodepleting regimen that we usually use is fludarabine and cyclophosphamide. That's the combination. So they usually go through fludarabine, cyclophosphamide for typically 3 to 4 days, depending on the product in a different regimen, usually. And then you get the CAR T cells a few days later. And kind of like, this is not really a chemotherapy talk, but this is just, I just put it here just for completion's sake. So the chemotherapy, fludarabine, this is an anti-metabolite, anti-purine analog. The cyclophosphamide, this is an alkylating agent that does cross-linking the DNA and causes cell death. And there's like toxicity that goes along with it, which I believe you're going to learn in a later talk. And then after you go through the lymphodepletion, then they're ready to get the CAR T cells. The CAR T cell administration in general, at our hospital, we just give it the standard pre-medications, Tylenol, Benadryl, and then they get the CAR T cells. And it's just like an IV bag. It just goes in. So after they get the CAR T cells, now we're gonna talk about the potential toxicities after they get the CAR T cells. So the CAR T cells, these are listed here, are the potential CAR T cell toxicities. I only want you guys to focus on the clinically significant the toxicities, and we're going to talk about the ones that are italicized. So I want you guys to kind of focus on the toxicities that are italicized, and then I want you to know the management primarily for the ones that are in red. So that's the CRS and the ICANS neurotoxicity. Okay. So first toxicity that we're going to talk about is called CRS, cytokine release syndrome. So this cytokine release syndrome is the most common CAR T cell associated toxicity. Okay, you can see that it happens in greater than half of our patient population. You see this. A lot of them, they will usually get some sort of CRS. CRS is this is the ASTCT definition. It's kind of just a super physiological hyperinflammatory response that's caused by the release of a bunch of inflammatory cytokines. So when these CAR T cells, they get to their target, they get activated, then they turn on a signaling cascade, which in turn causes T cell lysis, activation, release of cytokines. Then you get like this kind of like what we call a cytokine storm. So these cytokines are all released, and a lot of them are pro-inflammatory cytokines. Then you get this super physiological hyperinflammation reactivity, and that's what we call cytokine release syndrome. Okay. The kind of the cytokines that were identified that is primarily like fueling this cytokine release syndrome are listed here. It's your IL-6, interferon gamma, TNF alpha, IL-2, and so these are all pro-inflammatory cytokines. The typical onset, so this can happen typically, you're going to see is within the first few days. So typically like 2 to 3 days, you might start seeing some CRS. And it can last for about a week, sometimes even longer. But typically, this is just the typical duration. The onset may include fever, hypotension, tachycardia, hypoxia, chills. So these are typical side effects of typical symptoms of CRS. And then it may correlate with the efficacy of CAR T cell efficacy. Because when you think about it, you actually have to have the CAR T cells to actually get to the target cell, right? Target cancer cells. They get activated, and then they release all of these cytokines. And so in a sense, you kind of want to see a little bit of CRS because that kind of shows you that it actually is working. So it kind of correlates with clinical efficacy. And then, so here with this figure, I just want you to appreciate, so for CRS, those side effects that those clinical presentations that we mentioned, those are the common ones, but it can actually be a constellation of multiple symptoms that across various different organ systems. And this is just for you to appreciate all of the different ones, but the ones I mentioned are kind of more the common ones. The one on the right-hand side are according to the different products. Those are kind of the timeline of what it typically happens per package insert, but you don't need to memorize it or anything. It's just for completion's sake. And then there's some risk factors. There's some risk factors that have been shown that are associated with more severe CRS. So some risk factors include high disease burden. So if you think about it, right, logically, conceptually, if you have high disease burden, you have a lot of target cells. So it's easier for the CAR T cells to identify, and there's going to be more of that initiation of all those cytokines and all that. So actually more disease burden, higher disease burden, more chance of CRS. More CAR T cells. So if you're infusing more CAR T cells, it may also cause more interactions and therefore higher risk of CRS. ALL as underlying disease, and some other of these other ones. But yeah, it's just for you to appreciate some of the side effects, risk factors that are associated. There's some clinical markers that show more like persistent fever, super elevation of those pro-inflammatory cytokines typically have higher risk of CRS. And there's some biomarkers here, and I just want you to focus on these, the bolden one, CRP ferritin. So these are some biomarkers that after the patients get the CAR T cells that we kind of follow on a daily basis because they correlate nicely with the CRS development as well. So in order to understand, so these patients, when they do develop CRS, how do we manage them? What are we supposed to do? In order to understand how we manage it, we have to first understand how it's graded. So we're going to give it a grade. And the reason why we want to know the grade is because the management actually goes hand in hand with the grading. So this is the ASTCT consensus guideline that has the CRS toxicity grading. Okay. So when you're thinking about CRS grading, I want you to think three things. One is fever. Two is hypotension, so blood pressure. Three is hypoxia. So just think these three things. So all of the grades have fever, okay? And then hypotension. Hypotension is now seen starting in grade 2. Hypotension not requiring vasopressors is grade 2. Hypoxia with low flow nasal cannula is grade 2. Starting in grade 3, you have your hypotension that requires a pressor and or hypoxia that requires high flow nasal cannula. Grade 4, then you have hypotension with multiple vasopressors. And then this is like intubated for hypoxia. So this is the overall grading. So I want you to be able to kind of grade the patient considering their condition. And the CRS grade is determined by the most severe event, okay? So meaning that like if the patient, say they're on low flow nasal cannula, but they have hypotension that needs a vasopressor, what grade would they be? Grade 3, exactly. So for CRS management, it's divided into more supportive care measures and also pharmaceutical management. We're going to talk about more pharmacologic management first. So tocilizumab, remember when I was talking about the REMS? Tocilizumab. So this is first the drug of choice, the first-line therapy for CRS, okay? It's now gained FDA approval for T-cell-induced severe or life-threatening CRS. It's not approved for ICANS. It's the first-line therapy for CRS. Tocilizumab is an IL-6 receptor antagonist, so it blocks the IL-6 signaling. So IL-6, if everybody remembers, that's one of the pro-inflammatory cytokines that is highly mentioned about that's released in CRS, and it has been shown that it plays a key role in CRS development. So this tocilizumab, it directly blocks that IL-6 receptor-mediated signaling. The dosing, we're just going to talk about, this is the adult typical dosing is 8 mg per kg with a max dose of 800 milligrams. If the tocilizumab, you give a dose and say the patient still has active CRS, you can give a second dose, but it has to be within between an interval of 8 hours in between the doses. You can only get up to 4 doses total. So lifetime, basically, in total is 4 doses for this indication. So you can get up to 3 additional doses after the first dose. And then corticosteroids. So steroids used for CRS, we typically consider the steroids for CRS if the patient's CRS is refractory to tocilizumab. So first line I said, CRS, when you think of CRS, first thing you think is tocilizumab, okay? We don't do steroids unless tozi is not working. And the reason being is that there's general thought that with steroids, when you give the steroids, it actually blunts the response of the CAR T cells itself, okay? So it actually can affect the CAR T cells' persistence itself. So with that being said, we don't like to give steroids up front. We usually first do tocilizumab. If the tocilizumab is not working, then we consider the steroids. That's kind of the general line of therapy when we're thinking about CRS. So in terms of the grading, we talked about if you're grade 1 CRS, mainly it's just fever, right? So fever, we kind of just do supportive care measures. Starting in grade 2, that's when you would start thinking about more of your pharmacological treatments. So that's your tozi plus or minus steroids, starting in grade 2. So this is kind of just the same thing to reiterate. It's just in a table form, essentially, of what I just said. But you can appreciate that the doses for the steroids start going up as the CRS grading goes up as well. Another toxicity is called, it's a long name, so I'm going to only say it one time. Hemophagocytic lymphohistiocytosis macrophage activation syndrome. This is called HLH-MAS. So this is kind of like, I would say, kind of like CRS in like hyperdrive, okay? So it's like a super inflammatory, hyperinflammatory syndrome that actually has significant overlap with CRS. It kind of, treatment algorithm, it kind of follows CRS, and it usually kind of resolves with CRS resolution or sometimes further. And mainly is because it's not only, when these CAR T cells, they're activated, it's not only they're activated, They also affect the surrounding immune cells, including the macrophages. And so this is more like the macrophages also get super activated, and they undergo what we call hemophagocytosis. And that's kind of stemming this syndrome. But they also have similar side effects in terms of very high recurrent fever. They have all of these like hepatosplenomegaly, the triglycerides shoot up, fibrinogen level shoots up. Fibrinogen level goes down. Sepsis, like ferritin level shoots through the roof. So we kind of monitor all of these labs as these patients get their CAR T cells. And so general management is similar to CRS, but we actually, here at City of Hope, we do other mechanisms. We mainly use anakinra. The next one is neurotoxicity that we're going to talk about. So I want you guys to know CRS and then neurotoxicity, ICANS. So ICANS represents immune effector cell-associated neurotoxicity. The pathophysiology is that it suggests that there's like blood-brain barrier, all of those cytokines, it causes the blood-brain barrier disruption and endothelial activation. For those patients that do develop ICANS, a large portion of them, most of them also had CRS. So like here it says over 90% it's concurrent with CRS at the same time or following CRS resolution. So the timeline typically for ICANS development, it's a little bit later in the phase. So CRS usually comes first. Later in the phase, you can see typical time to onset is 4 to 10 days after getting the CAR T cells. And if they do develop ICANS neurotoxicity, it tends to stay a little bit longer as well. So it's about 2 weeks or more. It's not prevented or ameliorated by tocilizumab. This one, can anybody guess why? So let's think about this. So tocilizumab is what is it? It's a monoclonal antibody. So it's a monoclonal antibody. Is that large, small? What is it? It's large. Can it cross the blood-brain barrier? No, it cannot. So actually, the tocilizumab doesn't really work in terms of CRS is because it doesn't even cross the blood-brain barrier to start out with. So all that IL-6 activation that is ongoing in the CNS system, the tozi actually can't even get there. And that's something we're going to talk about later as well. So for ICANS presentation, these are the typical symptoms for ICANS listed here: tremor, dysphagia. They have seizures sometimes, delirium, just showing some altered mental status. Headache. Headache is a non-specific symptoms that's not included in the ICANS definition. They often have headaches, but it's considered non-specific. So these are all some of the symptoms that you might start seeing. Same, I have all of the onsets and durations listed here on the right for the various CAR T cell products. Don't need to memorize, again, just for completion. And then also, so similar to CRS, we also want to know the grading. How do we grade ICANS? So we utilize a tool, what we call is called an ICE score. So this ICE score represents immune effector cell-associated encephalopathy. So it's like a screening tool that we look at patients' orientation. Are they oriented? If they are, you get 4 points. The naming, can they name 3 objects? They can. They get 3 points, or you get deducted if you don't. Can they follow simple commands? And then also the writing skills. All of these, you get points. You add up the points. If your points is 7 to 9, it's grade 1. If it's 0 to 2, you're grade 3. So that's a very subjective screening tool that we use. And then, so for the grading, it takes into account the ICE score. It takes into account the level of consciousness, seizures, motor findings, and then elevated ICP. So kind of similar to how we talked about the CRS, right? Also for ICANS as well, the grading also goes by the most severe event as well. So say if the patient's ICE score is 6, but they have seizures, what grade would they be? Grade 3, I heard it, exactly. Yes, so it's the most severe event as well. So in terms of ICANS management, this is just a table also for your reference to kind of how do we manage ICANS depending on the grading. So if we look at grade 1, if patient's grade 1, typically it's more like supportive management. Starting grade 2, that's when you kind of start considering your first line treatment would be steroids. Okay, and then similar as the grade goes up, you add on more steroids and the steroid dose goes up, and then also more extensive supportive care management as well. So if we talk about neurotoxicity ICANS, first line treatment is steroids, okay? If the patient does not have concurrent CRS, because we're saying like for CRS, then you add on the tocilizumab. If they don't have concurrent CRS and only have ICANS, then they really only need the steroids. It's first line for neurotoxicity without concurrent CRS. So starting grade 2, we typically start with the dexamethasone 10 milligram is a very typical dose. And then depending on the grading, you can give it Q6 to Q12. If we get to the high grade ICANS, like grade 4, then we'll consider more of the much higher steroid dose of methylprednisolone, 1,000 milligrams up to that dose. Other supportive care recommendations would be when they start showing some ultramental status, you want to start doing some imaging, if possible, and also put in like a neuroconsult. Other ones is what we call is an on-target, off-tumor effect. So this is, remember when we talked about the CAR T cell target. So the CAR T cell, like if we're say Yescarta for say, that is a CD19, right? It's against CD19. CD19 is not only found on those B cell malignant cells, it's also found on B cells in general, right? So with these CAR T cells are transfused into the patient, they not only attack the cancerous cells, the CD19 positive cancerous cells, they also attack the normal B cells as well. So with that, that's what it means on target. So it's on target, but it's not tumor, off tumor effect. And with that being said, these anti-CD19 CAR T cells, they will cause B cell aplasia. So low B cell count, low antibody producing B cells, and therefore low hypogammaglobulinemia. And with that management, we typically check the IgG level, and then we give them IVIG to replenish. So here is all of the supportive care listed out here. You can review them. I'm not going to go over them line by line. It's for your reference. Some other supportive care measures are like we want to do tumor lysis prophylaxis, so that especially for larger tumor burdens, we give like allopurinol, infectious prophylaxis, because these patients are going to go through cytopenia phases. We do anti-infection prophylaxis. That includes like antiviral, typically with acyclovir, antifungal prophylaxis as well. Seizure prophylaxis. In the NCCN guidelines, it recommends to give these patients anti-seizure prophylaxis, including Keppra, for the first 30 days. And then, all of that is super exciting. And so which leads me to the last slide is basically the future of CAR T cells. this is, like I said, like it's gained so much traction. Now we're seeing so many more clinical trials that are ongoing because we've been seeing such a great response rate in primarily like the heme malignancies. But with that being said, there's those limitations, right? One is I talked about, like, currently FDA approved ones are all autologous. They're all only approved for your like patient's own cells giving to themselves. So that was like a very long, extensive process, and it's very high cost to make. So they're looking into, is there a possibility if we can make off-the-shelf ones? Like, can we use an allogeneic donor? And then so we readily have these off-the-shelf T cells always ready, so the patients don't have to wait through all of that process, the manufacturing process, the potential for failure of that manufacturing, you have to go through it again and all of that. Are there possibilities that we can do off-the-shelf one that's going to be safe? Like, does it have to be HLA matched? Like, so we're looking into that. Also looking into new targets to other cancers. So like right now, the FDA approved one, we have the CD19, we have the BCMA ones, right? What about some other targets, other cancer cells, including solid tumors too? Can we utilize that? Can we find more targets? Combination therapy, they're thinking about like combining CAR T cells with other immunotherapies, like other checkpoint inhibitors, to further harness that your own immune system. Suicide elimination switches. This is another one, like we said, these CRS or ICANS, if they get significant, they can be so much be life-threatening, and we've had those patient cases that it's life-threatening and taken their lives. So this, like, if we have a patient that's like high risk factor and they got this super severe CRS, is there a way that we can turn it off? Like, turn off these CAR T cells completely? Is there a way to do that? So there's also research going into, can we introduce some switches on the CAR T cell construct so that if the CRS does get too severe, we can just rapidly turn off all these CAR T cells together. Okay. So with that being said, we're going to go over the patient cases. Okay, go ahead and pull up your quizzes. So this patient case, 69-year-old female. She has relapsed refractory diffuse large B-cell lymphoma. Status post all of these chemotherapy regimens. Okay, so this is multiple lines of chemotherapy. Given this patient's disease status, what CAR T-cell product would be an appropriate option? What does everybody think? Yescarta. I hear a lot of C's. Yescarta. Yes. Okay, so the answer, yes, it's Yescarta, because first we can eliminate the multiple myeloma ones, right? The BCMA ones. Abecma, Carvykti, no. And then Tecartus, even though it's CD19, but this one's only approved for the mantle cell and the ALL. So yes, the answer is Yescarta. So that same patient, they got the Yescarta. 3 days after they received those CAR T cells, she starts developing persistent fever, mild hypotension, tachycardia, the O2 sat is sitting at 97% room air, and no signs of neurotoxicity. The labs are as below. You can start seeing the CRP is showing elevation, ferritin is going up. So according to the ASTCT consensus grading system, what CAR T cell toxicity is the patient experiencing? Grade 2. Yes, grade 2. Because remember when we talked about CRS grading, what 3 things do we talk about? Fever, hypotension, hypoxia. This patient do they have fever? Yes. Do they have hypotension? Yes. Hypoxia? No, they don't have hypoxia. Okay, so it's grade 2. So same patient, they have grade 2 CRS, right? We know that. And what is the most appropriate management of this patient's current condition? Select all that apply. continue to monitor, no intervention needed. B, provide vigilant supportive care, including antibiotics, antipyretics, IV fluid. Tocilizumab, methylpred, 1,000 milligrams. Provide supplemental oxygen. What does everybody think? B and C. Okay. Yes, let's go back one. Yes, B and C is the right answer because they spiked a fever. So even though with a fever, just a few days after CAR T cells, CRS is highly in the differential. But because the fever spike, we want to cover all of our bases. We still want to give the empiric antibiotics started. You want to give the antipyretics to bring down the fever, IV fluids, supportive care. And they have CRS now. Grade 2 CRS, we want to give a dose of tocilizumab. First-line therapy for is tocilizumab, 8 mg per kg. This is a high-dose steroid, 1,000 milligram methylpred. That one we will not reserve until very significant grading, we don't need supplemental oxygen. This patient is satting perfectly fine. Next, this patient, they received that tocilizumab. So they did receive that tocilizumab dose on day 3 after receiving the CAR T cells. Next day, patient remains febrile, still fevering, hypotension that's not requiring vasopressors. They have tachycardia. O2 sat is now 89% room air. And they're now showing symptoms of headache, mild tremor, and fatigue. But A and O is times 4. What is the most appropriate management for patient's current condition? A is tocilizumab, B, Dex, 10 milligrams. C is anti-seizure medications, supplemental oxygen, neuroconsult imaging orders, all of the above. What do we think? All of the above, yes. So we're going to do all of the above, yes. We can repeat the tocilizumab. It's already the next day. The dosing interval just has to be 8 hours apart. They are starting to show some neuro side effects. So we want to give a dose of dexamethasone, and seizure medications is appropriate as well. Supplemental oxygen, 89%, neuroconsult. Okay, and that's it. Thank you. Thank you so much, guys.
Thank you very much, Dr. Wei. For the first quiz, if any of you attempted it and submitted it, you would get 100%. Okay? All right. You'll get 100%. Okay. I'll be available for office hours if anyone needs anything.